Recording in progress.
Very good evening, one and all. Myself, Dr. Bhumesh Kumar Katkam. Welcome you all this Indian Association for the Study of Sexually Transmitted Diseases and AIDS, IAS-STD AIDS, the virtual academic platform by the name of Astinar-1, which is going to be held today, that is 23rd January 2022. So we healthcare providers, not only that, the whole globe is in a special situation of COVID-19 pandemic. We healthcare providers, one side we are treating the patient, at the same time we are teaching and updating ourselves, because unless until we update, we will be outdated. So that's why we have converted into the virtual platform. So in this Astinar-1, we are sensitizing by ourselves on sexually transmitted infections and AIDS. So this Astinar is a unique program of, it's a blend of academic awareness and sexual health awareness. Not only that, the PGs and SRs, they are the backbone for any institution. So we are sensitizing the younger doctors by this arranging fees for the PGs and SRs. And we are the top 2 PGs and top 2 SRs will be selected, and appreciation certificate and memento will be given. Not only that, the PGs or SRs, those who will get maximum points of Astinars, this total 8 Astinars, their HOD as well as the faculty and PGs will be honored in the physical conference of ASTICON, which is going to be held on 9th, 10th, and 11th of September at Hyderabad. With this, I welcome our IAS-STD President, Dr. Murugan sir, to give his welcome address.
Thank you. Respected past presidents, President-elect, my seniors, and my dear friends, good evening to everybody. Our IAS-STD and AIDS is very fortunate enough to have a wonderful team of Hyderabad team. Just imagine in this COVID pandemic period, if we are not having such a wonderful team, what would have happened? So they have conducted successfully 2 e-ASTICONs with more than 1,500 to 2,000 attendees, and now they are going to start the Astinars. We are having a wonderful team under the head of Dr. Narasimha Neta and Bhumesh Kumar as a secretary, and our scientific committee, especially our Bhumesh Kumar. Just Dr. Bhushan ji put a line, he made it a road. If we are showing any stone, he will make it a sculpture. So wonderful. That is the Bhushan Kumar. So he made it as Astinar serial. So this is the first Astinar, and we are very happy to be there. And one more thing, he also sensitized everyone on genital health. So that is very important. And genital health is very, very important, which is neglected by many other professions. So we have to take the torch, and this is happened just because of our Hyderabad team. So that is another credit. And moreover, he is honoring Astinar stars, our past presidents. So that is also very, very happy to be appreciated. And this he is conducting the e-ASTICON, Astinars, everything without any expense to the parent organization. That is also very, very important. And our hetero healthcare people are worth to be mentioned, and they are backbone with the Bhumesh, and they are helping to conduct all these things successfully. I have to thank these hetero people very much, especially Nehru Datti, Guru Prasad, and the other teams. So that is also very important. And I request all the faculties, especially anyone who had not been member so far, please become a member. And I request all the professors and other faculties, especially our postgraduates and senior residents, to become a member. The membership form is available in our website, that is IASSTD8.org. If you put like that, our website will be opened, and you can find the membership form. In the membership, there is an option for membership. You can open it, you can download it, and you can become a member, because you are going to keep the IAS history rolling down in future. So please, those who are not becoming member, I request you sincerely to become a member. With this, the learning process will continue. I am also very eager to hear from the experts. Thank you very much.
Thank you, sir. Thank you for your kind words. Now I request our organizing chairman, Dr. Narasimha Rao Neta, to express his views. Unmute, sir. Unmute yourself. Neta, sir, unmute. You are muted. Neta, sir, you are muted. Neta, sir, you are muted. Now.
Very good evening, all of you. Welcome to all for Astinar, Astinar. I'm very much happy to be here today, being conducting the Astinar-1. I'm congratulates and thanks to organizing our EC committee of national body to giving and believing us to run the show of the Astinar series around 8 till the end of the ASTCON 2022. I also thanks to the hetero group to giving the support and conducting successfully. Definitely, I thanks on behalf of the organizing committee. I came to know that many PGs and SRs are not up to the mark in the STI and AIDS. So that is the correct right time to sensitize them. Even the many practicing people, they are little not much up to the mark. So this is the right time to sensitize and educate them. They can clarify in this forum. I hope all will enjoy this academic feast, and also request to tell your colleagues to participate and make this program grand success. Thank you one and all. Thank you very much.
Thank you, sir. Thank you very much for your kind words. So now we'll move on to the scientific session. So for this today's chairpersons of Astinar-1, I invite Dr. R.N. Datta sir and Dr. Govil sir. Srinivas, the CVs of the first. Yeah, Dr. R.N. Datta needs no introduction. He is senior most the doctor from all over India. He is a former president and a lot of credentials on his name. Welcome, sir. Please come on to the dais and occupy the chair. And the second chairperson, Dr. Dinesh Govil, sir. Dinesh Govil, sir, is also former president of IASSTD8. He needs no introduction. He's well-known person all over India, in UK, Uttarakhand, and all over India. Sir, welcome. And this podium is yours, and over to chairpersons. Yeah, unmute, sir. R.N. Datta, sir, unmute yourself. You are muted. The first speaker, CV. Srinivas.
Thank you. Good evening, and I thank Dr. Murugan and the ISSTD team, Dr. Neta and Dr. Bhumesh and the organizing team for this wonderful Astinar, which is being conducted. Now let me introduce Dr. Yogesh Marfatia. I think there is very few people who do not know him. He is a boss in this field. and the professor of Skin Video Vesiculates Institute, and there are a lot of honors towards him. He was the past national president of our organization also. So instead of telling so many things, let me introduce and call Dr. Yogesh Marfetia to go along with his mm, talk. Yogesh,
Yes, Srinivas,
Yes.
Yogesh
the table is
Marfat,
yours.
PPT.
Yes. So,
Yes, sir, just a minute.
yeah, go ahead. Full screen. So, good evening, everybody. And I congratulate the team of our association for organizing this Astinar. It's a brilliant idea. Coming to topic, the topic given to me is overview of STDs in India. So it is, I'll be not strictly restricting to the topic because little data is available on STDs, but I have decided to go for generalized overview of STIs globally and of course in India. Next slide. Yes. So we all know that this is a global health concern, and morbidity and mortality as a consequences of STI is enormous. The impact of STD includes its impact on quality of life, sexual and reproductive health, including fertility, newborn health, and child health. STIs facilitate transmission of HIV. It causes cellular changes that precede some cancers. Another important problem is antimicrobial resistance expressed by Neisseria gonorrhoeae is a major public health problem. Next, please. Yes. So what are the health implications of STI? So it is health implications are underestimated. Cervical carcinoma due to sexual transmission of HPV and liver morbidities due to sexual transmission of HBV are not considered while estimating the health impact of STI. Over 90% of global burden of STIs occur in low and middle income group countries where there is limited or no access to diagnosis. STDs in vulnerable populations like LGBT, sex worker, and children are underrated. Next. So coming to global scenario. So due to current socio-cultural and economic factors coupled with easy accessibility to cell phones and internet has resulted in increased sexual exposure with resultant transmission of STIs. There are remarkable changes in sexual behavior of and practices, particularly so, women are being more affected. Oral and anal sex is more frequently practiced, and the burden of oropharyngeal as well as anorectal STI is hardly quantified. There is increasing trend to use sex toys and gadgets, which will transmit STIs and can be a source of reinfection. Next, please. So coming to global scenario. So more than 30 different pathogens are known to be transmitted through sexual contact. Daily, almost 1 million STIs are acquired worldwide. And in India, 6% of adult population, that is 15 to 49 age group, 6% are getting RTI, STI every year. This is a NACO estimate. Now, globally, the most common STIs, which are of course treatable, 4 treatable STI, they are chlamydia, gonorrhea, syphilis, and trichomoniasis. The figure is 376 million. The most important being silent viral STI. These include HSV, 500 million, and HPV, 290 million. Of course, syphilis is, having still a reasonable number of cases, that is almost 1 million cases, 35 lakh still, adverse birth outcome, including 2 lakh stillbirth. Next. Now coming to India. So this is a figure from a leading STD clinic in public hospitals. So most common being herpetic GUD, then genital wart and syphilis. These 3 are common, and of course in female candidiasis and bacterial vaginosis are common. Next. Yes, so this is just to show that this is a data of a clinic, and it is just to show that yes, in female vaginal discharge common, and of course genital ulcer disease, herpetic, genital warts, and even syphilis they are showing this statistic or data. Next. So the trend is, of course, there is increase in discharge cases, but by and large, syphilis, genital warts, it is more or less hovering at around same rates. Next. Yes, urethral discharge. So this is interesting. So now the causes of urethral discharge, there is some shift as compared to gonococcal. Yes, it is still 1/3 of cases, but the cases due to ureaplasma, parvum and Mycobacterium hominis are also increasing. Of course, herpes is also one of the cause of urethral discharge as per data from our own STI clinics. Next. Yes. Now coming to HIV scenario in India, so 0.22% is the HIV prevalence in adult aging 15 to 49 years. The highest in the states of Mizoram, Nagaland, Manipur. Many states are having above national figure like sorry, Delhi, Maharashtra, Goa, Tamil Nadu. Next. So India has highest global burden of PL-HIV accounting to 33.5% in children, 44.3% in adults. Annual new infection rate is 57,550, and this includes 10% in the children below 15 years. Mother to child transmission rate is almost 27.45%. Next. Yes. Now coming to syphilis in various groups, this is of course a global scenario. So more than 1% of the pregnant female are, VDRL positive. Sex worker, the rate is 5%. MSM, the rate is up to 5%. Next. Yeah, this is from Indian clinic data. So they are showing rising trend at a tertiary care hospital. The figure reported cases of syphilis increasing. The figure is 13.3% during 2017-2080. WHO estimate that each year 11 million new cases of syphilis occur globally in adult population. Next. This is another report from Indian clinic, STD clinic, and this is showing that in the years to come, will there be a rise in number of tertiary syphilis cases as a consequence of rise in proportion of latent syphilis? Has the historical great imitator changed to covert devil, that is tertiary syphilis? So they have reported cases of tertiary syphilis, and the message is that the need of the hour is a large-scale screening program to discern the prevalence in other parts of the country and curtail the risk of this. Particularly, they are focusing latent and tertiary syphilis. So, in such syphilis, it seems that it is rising. Next. Yes, congenital syphilis. So, what is the syphilis seroprevalence among pregnant women in India? 0.38%. This is, of course, the old data, and annual burden of syphilis among pregnant women is about 1,03,000, out of which 53,000. So any adverse outcomes, which includes fetal loss or stillbirth in 21,000 cases, neonatal death 9,213 cases, premature or low birth weight in 6,161 cases, and newborn showing clinical evidence of syphilis in 16,000 and some 300 and odd cases. Next. So what government envisaged and targeted? So the target was to eliminate parent to child transmission of syphilis by 2017. I don't know what we have achieved in this particular aspect, and less than 0.3 cases per 1,000 live birth by 2017. I tried to find out the recent update, but exact status of this program is not available. The target was to cover 95% of pregnant women under antenatal care, and out of this 95% must be tested for HIV, and out of those HIV tested reactive, 95% must receive treatment. That was the goal of this particular program. Next. Now coming to gonorrhea and chlamydia. So the global concern is antimicrobial resistance, and it has threatens our ability to treat and control gonorrhea, its complication and sequelae globally. There is high rates of quinolone resistance, increasing erythromycin resistance, and emerging resistance to extended spectrum cephalosporins is reported as per AMR survey. Currently, treatment failure due to injectable ceftriaxone used as last line drug is also reported. Hence, dual antimicrobial therapy, injectable ceftriaxone plus azithromycin is recommended. Next. Yes, this is just to show that this figure, same Indian data. There is spectinomycin, of course, resistance is not reported. Cefotaxime and azithromycin to a lesser extent resistance is reported. And penicillins, tetracyclines, high rate reported. So still spectinomycin and some of the cephalosporins works. Next. Yeah. Now coming to HPV. So HPV is a very common. Most sexually active women and men will be infected at some point of life, and some may be repeatedly infected. The peak time of acquiring infection is after becoming sexually active. What is interesting is that HPV is sexually transmitted, but penetrative sex is not required for transmission of STD. This is very much important as far as HPV dissemination is concerned. Skin to skin genital contact is well recognized mode of transmission. Next. Yes. So HPV virus, they are small DNA particle, and the prevalence on skin is 61%, vagina 41%, mouth 30%. Non-cancer causing type of HPV, especially 16 and 18, can cause genital warts and respiratory papillomatosis. As we all know, genital warts are very common, highly infectious, and affect sexual life. Next. Yeah, HPV and oral cancer. So HPV as a oral cancer is now next to tobacco. So after tobacco, the next common cause of oropharyngeal malignancy is HPV, and it causes focal epidermal hyperplasia or Hague disease, oral squamous papilloma, oral condyloma acuminata, oral squamous cell carcinoma, leukoplakia, recurrent respiratory papillomatosis, and WHIM syndrome, that is warts, hypogammaglobulinemia, infection, and retention of mature neutrophils. Next. Yeah. So what is interesting and important about HPV is that the infection is subclinical and multifocal. What we see clinically as a warts is just a tip of iceberg, as shown in the picture. And the HPV colonizes in anogenital canal, potential of transmission due to viral shedding, even when this is most important, the person is asymptomatic. So both herpes and HPV, this is a real problem of asymptomatic transmission. Most female with vaginal infection also have cervical infection. Hence, there is potential for spreading from asymptomatic cases. Next. Yeah. Key issues in HPV vaccination program, right? So good vaccination coverage can eliminate even genital warts to a large extent. Vaccination among both boys and girls before sexual debut is crucial. Importantly, in India, this is not promoted, and I sincerely believe that we as an STD specialist should promote this particular vaccine to prevent not about carcinoma, but to prevent even genital wart. MSM would not benefit from a female only vaccination program. So gender neutral program is important, and this will result in lowering the infection pool of HPV in general population and ultimately HPV related disease for both. Next. Yeah, a remarkable herd effect was observed in young unvaccinated heterosexual male as a consequence of vaccination in female. So I think again and again the message is we must promote this particular nonavalent vaccine. And this Australian study report that due to promotion of this vaccine program, there are incidents of juvenile oral recurrent respiratory papillomatosis has declined, even though none of the cases mothers received HPV vaccination pre-pregnancy. So I think herd effect is also there. So I mean, vaccination promotion is important. HPV vaccination promotion. Next. So regarding HPV testing, particularly this pap smear, etc. But the limitation is that cytology-based screening is to be repeated, and it fails to detect glandular lesion. So the focus should be shifted to HPV DNA based screening. It offers less frequent testing, will improve detection of adenocarcinoma and facilitate prevention of invasive cervical cancer and precancerous lesions. So it is the high time to adopt HPV DNA based screening, and at least it should be available in government institutes. Next. Now coming to HSV. So what is important and interesting in this front is that HSV1 is becoming a cause of genital herpes. Usually we consider HSV2 as a common cause. Why this has happened? So as per US study, there is decline, or even India, there is definitely decline in oral herpes due to HSV1 in children. And when they will reach coital debut, they will not have protective antibodies against HSV1 genital acquisition. So role of HSV1 as STI pathogen in short is increasing. Next. So now talking about emerging STIs, that is Zika virus. So Zika can be passed through vaginal, anal, oral sex, and sharing of toys, etc. Transmission can occur even when infected cases are asymptomatic or pre-symptomatic. Seminal fluid, the Zika virus remain for a relatively longer period. Mechanism of intrauterine transmission of Zika and cell types involved remain, of course, unknown. But the message is that it can cause fetal malformations and abnormalities in central nervous system development and macrocephaly. So condom definitely protect. Next. Coming to Ebola virus. So here also, its persistence in semen and vaginal fluid, of course, is reported. And safer sex is the best option. Even safe sex should be practiced by male survivor of this particular virus, Ebola virus, for 12 months following onset of symptoms or until semen test negative for Ebola. Regarding COVID, it can spread through direct contact with saliva or mucus, and traces was found in semen, but sexual transmission is still needs to be proved. Next. Yes. Now coming to another thing, we all have promoted syndromic approach. So what is the diagnostic accuracy of syndromic approach? So going through one by one. So urethral discharge in male particularly. So its sensitivity is very good, but asymptomatic chlamydia in Nigeria is not addressed. Even Mycoplasma genitalium, Trichomonas vaginalis are not covered, and treatment failure is also not covered. Coming to vaginal discharge. So vaginal discharge due to vaginal infection, it is adequate for, trichomoniasis and bacterial vaginosis, but it is not proper for, chlamydia, trachomatis, and Neisseria gonorrhea. So, the message is that for vaginal discharge syndrome, there are a lot of issues to be resolved before, of course, at a periphery level or, non-specialist clinic, we promote syndromic approach, but much needs to be considered. Or a component of some investigation needs to be added. Next. Yes, lower abdominal pain, it's satisfactory, but there is over treatment. Anorectal infection accuracy is low because majority of cases are asymptomatic. Next. So the drawback of syndromic approach include it is not designed to screen and detect asymptomatic cases, and hence is not useful for finding case finding. Overexposure to drug can cause resistance, aggravate AMR problem. Even risk of adverse drug reactions are more. Not designated to cover etiologies of persistent urethral discharge, including Mycoplasma genitalium and other. And Mycoplasma genitalia as an important causative agent for urethral and vaginal discharge and PID, it is not covered in syndromic management. So there are many flaws in currently adopted syndromic approach. Next. Yes. Now coming to this important thing, what is the amended POSCO, that is Protection of Children from Sexual Offense Act, right? Variety of offenses are covered under it. I'll not go through the list, but the bottom line is important. According to the Act, every crime of child sexual abuse should be reported. If a person who has information of any abuse fails to report, even they are punishable. See, this is a real tricky problem. Once in a while in our clinic or in our hospitals, institute, such cases are there, and it is very difficult for us to become, to report it to the authority or to the police like that. So this is a real tricky situation, but everybody must be very sure that you are supposed to report if you find wart or a condyloma lata in children. And if not, there are some medical legal issues as well. This is what I wanted to say about this rule. Next. Now coming to last part of my talk. So regarding STI prevention, so coming to condom next. We have talked that there is a lot of viral infection in terms of human papilloma virus and herpes simplex virus and even syphilis. So all the three are not very well protected as far as male condom is concerned. That is human papilloma virus, herpes simplex virus, and syphilis. Next. Coming to female condom, so I think still in India, female condom, I'm not seeing or knowing about it, how far it is used by high risk female, and vaginal microbicides, of course, are not available. Next. Yes. So see, this is unfortunate that IPL is promoted, but IPL never protect against any STI. We all know that. And second most important thing is that there is promotion of pre and post sexual exposure prophylaxis as far as HIV is concerned. And the promotion of these type of things like IPL, like pre and post sexual exposure prophylaxis, it is detrimental as far as STI dissemination is concerned. And I think there has to be some thought given to it or some representation from our association. Next. Yes, regarding circumcision is well known to protect against HIV and provide some protection against STIs such as herpes and HPV. Unfortunately, in India, the percent is not even 2-3% of the male. So the percentage is very low, except some as a religious practice, but by and large, larger proportion or majority of males are not still circumcised, which can definitely promote even genital health, which is our ultimate aim. Next. Yes. So what are the key points of this particular overview of STI? So these are the global public health concern. Burden of morbidity and mortality as a consequences of STI is enormous. Current socio-cultural and economic factors coupled with easy accessibility to media result in increased exposure sexual with resultant transmission of STIs. There are remarkable changes in sexual behavior and practices, and it is difficult to estimate prevalence of resultant extragenital STIs. See, this is very much important. We don't know what is going on as far as extragenital STIs are concerned. Secondary syphilis cases are on rise. There is role of saliva in transmitting oropharyngeal and anorectal gonorrhea. This is an interesting thing that even saliva can transmit oropharyngeal and anorectal gonorrhea. Antimicrobial resistance to Neisseria gonorrhoeae is reported to the last line drug, that is injectable ceftriaxone. And high level of AMR is also reported with mycoplasma organism as well. So I think this is what I wanted to say. Last slide is just to say thank you. Oh, sorry, some more point. So sorry, I missed it. So HPV, yes, nonavalent HPV vaccine is recommended to effectively prevent this infection and some cancer. Male vaccination is also recommended as far as HPV vaccines are concerned. DNA-based screening for HPV is more accurate than routine cytology or pap smear. Role of HSV1 as a cause of genital herpes is increasing. It is essential to integrate rapid diagnostic test and point of care test to strengthen quality of STI case management based on syndromic approach. See, this is important. A point of care test. Now we have it for COVID. Why not for STDs and HIV in our clinic or like that? Male and female condoms are the only multi-purpose technology that prevent against STI, HIV, and unwanted pregnancy, as compared to things like IPL and pre and post exposure prophylaxis, which I have already discussed. Circumcision definitely supplement other STI prevention strategies, and it should be promoted as far as STI and genital health is concerned. So I think, yes, this is the for sure. This is the last slide. Thank you very much for patient hearing.
Well, thank you. Malfatya, can you hear me?
Yes, sir.
Yogesh, it was a nice talk, and well, good evening to everyone. Umesh, Narasimha Rao, Murugan, it's a pleasure joining you people and listening to the very first interesting talk. Thank you, Umesh.
Chairperson, over to chairpersons. Second chairperson.
May I have the slide of
Second CV.
Dr. Hanumanthaya is professor at Kolar. He has over 27 years experience with over 30 publications. I request Dr. Hanumanthaya to present his presentation on diagnosis, clinical diagnosis and differential diagnosis of syphilis. Dr. Hanumanthaya, over to you.
Yes, sir.
Srinivas, PPT, Hanumanthaya PPT.
ನಮ್ದು ಮಾಡ್ಬೇಕು ನಮ್ದು ಮಾಡೋದು ನಮ್ದು ಮಾಡು ಅಂತ ಹೇಳಿದ್ರು ಅದ್ರ ಚೇಂಜ್ ಮಾಡ್ತೀನಿ ನಾನು ಒಂದು ನಾಲ್ಕು ಅಲ್ಲೋಗ್ರು ಅವ್ರು ಮಾಡಿದ್ರಾಗ ಚೇಂಜ್ ಏನವ ನೀನು ಹೇಳಿದ್ರೆ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡಿದ್ರೆ ಕೇಳಲ್ಲಪ್ಪ ನಿಮ್ದು ಪ್ರಾಬ್ಲಮ್ ಇದೆ.
Hanumanthaya sir, you are muted. So unmute yourself. Hanumanthaya sir, please go ahead.
Sir, whether I am sharing or you are sharing? Okay.
No, we have shared already.
Yes, sir.
Just go ahead.
Sir, please, next slide. No, sir, this is not the one. I will share my slide. This is not correctly arranged.
Okay, will you share?
Yes, sir, I will share.
Okay, Srinivas, you stop sharing. Yeah. Perfect. Slide mode.
Sir, I am extremely thankful to all senior colleagues, especially Dr. Yogesh Marfatia.
Sir, put it in slide mode, sir. Put it in slide mode.
Slideshow mode.
Easy slide. Yes, sir.
Slideshow. No. From the beginning.
Set up slideshow on the right. Right. Go right. Yeah.
Okay.
Still it's not come.
In the down also it is there in the slideshow. Just down. Yeah. There.
Click.
Yeah, click.
Yes, sir.
Click it.
Oh.
Is it visible, sir?
Yeah, visible. Go ahead.
Yes, sir. My respectful regards to all senior colleagues, especially Dr. Yogesh Marfatia, the way he enlightened about the magnitude of syphilis in India. Straight away, I will come to clinical aspect of syphilis. Entire world was aware of this particular disease. Each and every country had its own name. Especially in India, it was called as a Ferengi disease, Great Pox. So many names are there. Every infective agent is having a 100% accurate taxonomic position. It belongs to kingdom bacteria. The phylum Spirochetes, I will explain a little later. The genera Trypanoma, species Trypanoma pallidum. One of the best definition so far I have seen that is the Stokes definition. He so beautifully tells it's an infectious disease, Trypanoma pallidum, of great chronicity, systemic from the outset, capable of involving practically every structure of the body in its course, distinguished by florid manifestation on the one hand and years of completely asymptomatic latency on the other. It is able to simulate many diseases in the fields of medicine and surgery, transmitted to offspring in man, transmissible to laboratory animals. Sir William Osler so beautifully quoted, syphilis simulates every other disease due to its multiple and varied protein clinical manifestation. It has been named the great imitator and mimicker. It is the only disease necessary to know. One then becomes an expert dermatologist, laryngologist, psychiatrist, eye specialist, and an expert diagnostician.
Slides are not moving.
Slides are moving, sir. Sir,
Slides are not moving.
No, it's not moving.
Sir, can I continue? Sir,
No,
can I?
slides must
We are not able to see your slides.
slides.
Srinivas, can you help him?
Yes,
Make
sir.
it slide mode. Slide mode is not done actually.
And it is not moving also.
Srinivas,
It should be in a slide mode.
Sir, can you share again, sir?
yeah, you share it.
Select the first
Maybe
icon,
slide
sir,
mode.
from the beginning.
Put it.
What happened, Srinivas?
Maybe I think any technical issue on his laptop, sir.
Okay, then you share it. Sir,
So we
Anmantai sir, you stop sharing. From our
Yes, sir.
side, we will share. Then you can go ahead.
So
Yes,
we
sir.
don't have updated slides, sir.
Sir,
That one.
I have sent the slides part 1, part 2, part 3. Part 1 should be the first, so that it will be continue. Part 1.
You part 1 part, na?
Yes, sir. Part 1, part 2, part 3.
Oh, three parts are there.
Yes, sir. Yes, sir.
You start, sir. You continue. You tell. You go ahead.
Yes, sir. Yes, sir. Trypanosoma pallidum cannot be cultured in vitro because it absolutely lacks the enzymes necessary for even simplest of Krebs cycle and oxidative phosphorylation. What God has given for Trypanosoma pallidum to survive, He has given such a beautiful genes which encode transporters of amino acids, carbohydrates, cations from the host. Hence, it is 100% intracellular obligate parasite. Trypanosoma pallidum is a fine motile spiral organism measuring 6 to 20 microns in length, 0.1 to 0.18 microns in thickness with characteristic motility. It has a regular spirals which helps in differentiating from other non-pathogenic trypanosoma. The genomic sequence is 1.14 million base pairs. What is the specialty? The minimum infectious dose, 57 organisms. Biological multiplication time, 30 hours. Trypanosoma concentration generally reaches 10⁻⁷. It means 1 crore organism per gram of the tissue before a clinical presentation appears. The median incubation period is 21 days, usually range 9 to 90 days. Average inoculum of 500 to 1000 organisms are deposited during act of sex. The specialty of this organism, 20% of it is lipids. That too, cardiolipin, phospholipids. Friends, I told you I will tell little more about the spirochete. See, this is a spiral hair-like structure. This is a spiral hair-like structure. Hence, it is called spirochete. Tryponema. Trypo means exactly it bends in the middle. Exactly it bends in the middle and can move in this direction efficiently or in this direction efficiently.
Please move the
Hence,
slide.
it is called
Please move the
tryponema.
slides.
Slides are not being moving.
Yeah, this Srinivas will take care, sir. So this is not moving. Srinivas, you share the slides.
He should stop.
Yeah. Srinivas, are you ready with all PPTs?
Stop sharing.
Anumanta sir, you go ahead. You speak. Srinivas, are you ready with the PPTs?
Hanumanta Sahab, once you finish one
Yes,
slide,
sir.
you say next. Then I think
Yeah.
Mr. Srinivas can change the slide.
Yeah.
Yes, sir. So now next slide, sir.
Srinivas, Cherji.
Srinivas.
Srinivas, any problem?
Anumanta sir, unmute yourself, sir. Unmute.
Yes, sir.
You go ahead. Orally, you tell. No problem. You go ahead.
Then I have to share the screen.
No, the slides are not moving, sir. You go ahead. The Srinivas will take care meanwhile.
Yes, sir. See this particular Trypanoma pallidum, such a wonderful organism. The end of this particular organism is having a blepharoblast. By its scar-through movement, it makes a hole into the stratum corneum, then entire epidermis, dermis, and it goes much deeper inside the dermis. The transmission is usually 100% sexual contact, but definitely once in a way through infected blood, transplacental route, or accidental to medical personnel. We classify syphilis into acquired syphilis and congenital syphilis. Acquired syphilis is up to first 2 years is called early infectious phase. It consists of primary stage, secondary stage, recurrent stage, and early later stage. Late non-infectious phase, diagnosed after the end of second year of infection. So it is called late latent stage and tertiary stage. Tertiary stage, it affects the covering structure of the body, supporting structure of the body, and viscera. And cardiovascular and neurovascular syphilis, sometimes called tertiary syphilis or quaternary syphilis. Congenital syphilis, there is no stage analogous to the primary stage. So whatever we are having, early congenital syphilis, late congenital syphilis, and stigmata. Incubation period. Yes, friends, it depends upon the quantum of initial infection during act of sex. How many organisms are deposited? How many organisms are deposited on the genitalia? And how many days they have taken to reach 1 million number? One organism to become 2, it takes on an average 24 to 36 hours. If heavy organisms are deposited on the day of sex, within 9 days we may get the infection. Or if the number of organisms are extremely less, it may take 90 days. Friends, the primary stage. What is primary stage? It is a stage from successful infection to the time taken for chancre to heal.
Go ahead. Sir, which slide, sir? Anumanta sir, which slide?
Sir.
Go ahead. Srinivas, go ahead.
Okay, sir.
Primary stage. This is correct, sir. 40 number.
Okay. Just you say
okay,
next.
sir, I'll go back.
It's okay. It's okay.
Yes,
Next.
sir. Next slide. 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 Yes. Now, primary stage. This is enough. Go back. Primary stage. Next one slide back. Primary stage is the stage from successful infection to the time taken for chancre to heal. It is a single ulcer. It is a painless ulcer. It is a clean ulcer. It is an indurated, well-defined ulcer. The lymphadenopathy is present, heals with the scar, with the treatment, and even without treatment, and progresses to secondary stage. Next slide. What are the sites where primary ulcer is seen? 90% of the time, it is the genital region, sometimes extragenital region. In the male, coronal sulcus, glans penis, frenulum, prepuce, shaft of the penis. In the female, cervix, labia, vulva, urethra. Extragenital, yes, any erogenous region. During act of sex, some parts of the body get attracted. So those all the areas wherever more attraction is there, we can get extragenital lesions. Next, sir. See, this is a beautiful ulcer. It is a single ulcer. It is a clean ulcer. Borders are 100% well defined. The surface, it looks almost clean. Absolutely, there is no pus. So here, 100% well circumscribed ulcer. Borders are 100% well defined, indurated border. And absolutely, there is no pus. Next slide, sir. Next slide. See, one more. It is an indurated ulcer. Sir, what about other slides? Part 2.
We'll share. Srinivas, share part 2. Srinivas. Okay. Go ahead.
Next slide. Next slide. Srinivas, next slide. See, this is the ulcer in the vagina. It is in the vulva. It is a kissing ulcer. Next slide. See, it is a peculiar ulcer. It is a superficial ulcer, shallow ulcer, tender ulcer. All the clinical signs of primary syphilis are not there. But unfortunately, the dark field shows trypanoma pallidum. It means it is a mixed chancre. Clinically, it is 100% very difficult even to think there was a primary syphilitic, because absolutely there are no clinical signs except dark field shows trypanoma pallidum. Next slide, sir. Perianal region, oral lesion on the tongue. Next slide, sir. First question comes to our mind. Why there is a single ulcer in syphilis? Because of underlying endarteritis obliterans. Endarteritis obliterans. Why chancre is clean? Because absolutely there are no neutrophils. Unless neutrophils are there, pus will not be formed. Why chancre is hard, button-like induration? Because tightly packed plasma cells in thick mucopolysaccharides in the base of the ulcer. Next slide, sir. Why chancre is painless? Because all activated plasma cells secrete perforins. These perforins cause perforations in the local axons. Hence, these axons do not send pain impulses higher up for pain perception, and hence patient do not feel pain. The 4 characters of a primary chancre are painless, single, indurated ulcer. Differential diagnosis: soft chancre, granuloma venereum, lymphogranuloma venereum, herpes genitalis, genital scabies, Behçet's disease, drug eruption, and traumatic ulcer. Next slide, sir. Next slide. So, this is the primary syphilis, and here you see multiple superficial shallow ulcer. Here single ulcer. There is an inflammatory bubo. 100% it is going to form pus, and it is a monolocular abscess. Next slide, sir. Next slide. It is a syphilitic ulcer. Here, there is a mass of granulation tissue, tumor of a granulation tissue, granuloma venereum. This is the intracellular, intracytoplasmic, the inclusion bodies. Earlier, we used to call it as a Cali-Memenobacterium granulomatis. Today, we call it as a Klebsiella granulomatis, granuloma venereum. Next slide, sir. This is a syphilitic ulcer, and here there is a lymph nodes on either side. Usually, lymph nodes are enlarged. Inguinal ligament is much more prominent. On either side of the inguinal ligaments, lymph nodes are enlarged. We call this particular sign as a groove sign of green blood. If suppuration, if properly not drained, it will form a sinus. Next slide, sir. This is a syphilitic ulcer, and here initially there are grouped vesicles, and they formed erosive lesions, erosions, and mild ulceration, classical of herpes genitalis. Next slide, sir. This is the syphilitic ulcer, and there is a most important itchy lesions, itching in the family members, and usually because of itching, papules, excoriations, and echorascabi, genital scabies. Next slide, sir. Next slide, sir. So this is the what we call the reactive dermatosis. Reactive dermatosis, clinically the lesions are extremely less. Multiple ulcers with central yellowish fibrotic base. Yellowish fibrotic base, typical of Behçet's disease. Next slide, sir. Third part. So this is the drug reaction. One is due to arglitazone and second is due to brufen. Next slide, sir. Next slide. This is traumatic ulcer. So secondary syphilis, syphilis D-emboli, primary stage is absent and the patient directly presents with the features of secondary syphilis. Next slide, sir. It may be usually mucocutaneous involvement, non-vesicular, non-pruritic, widespread, bilaterally symmetrically distributed. Next slide, sir. Next slide, sir. Next slide. Bilaterally okay, go back. This clinical photo. Bilaterally symmetrical, coppery tint colored, asymptomatic lesions. Next slide. On the hands, on the feet, the macular syphilis, and here scaly lesions. Next slide, sir. Annular plaques. This is a split papule. Next slide, sir. Broad-based, flat-topped, moist lesions, highly infectious, condyloma reta. Next slide. Next slide. See, in HIV positive patients, the lesions, what we call the rupioid lesions. This is the typical of syphilis, secondary syphilis with HIV positivity. Next slide, sir. See, I have taken maximum the literature from Dr. Sharma sir, King A. Nicole, and Vasishtha. So thank you very much. Next slide, sir. Next slide, sir. Namaskar.
Thank you, Dr. Hanumantaya, for your elaborate and comprehensive description of syphilis, which was very nice. Now I think
Srinivas,
third
CV.
speaker. The third speaker is Dr. Sunil Sethi. You can see he has a lot of feather to his credit. He is a former executive member of World Congress of International Union Against, and then he was awarded ICMR International Fellowship, etc. A very dynamic person from Chandigarh PGIMR. So, Sunil Sethi, you can start your presentation. Dr. Sethi?
Okay, sir, I'll share it. Someone else is sharing.
No, you share, sir. You say.
Okay.
Put it in slide mode. Perfect.
So good evening, everyone. And it has been wonderful to see all of you after such a long time after this pandemic. And I would like to thank Dr. Bhumesh for inviting me to this particular seminar, unique seminar. I must congratulate him for holding such a wonderful, unique webinar. I think I heard yesterday someone saying it's the first time in the history of this STCon that such kind of event is being held. So I'll be speaking on the laboratory diagnostic challenges of syphilis. And this is our, you see, our laboratory, that is Regional STA Reference Research and Training Center. And we are conducting all kind of assays, all the cultures for all the STIs, regarding the culture of, as well as all the serological, as well as the sequencing, and all the molecular techniques we are doing in this center. So as Dr. Malfatti said, you see what is back. Syphilis is making a comeback, and particularly is increasing, particularly in the MSM population. And if you see from our center, in the previous years, it has increased from 5% in 2016 to 14% in 2020. This is a 5 years data which I'm showing. So this is a culprit actually. This spiral thin helical organism, which is about 10 micrometer in length and 0.1 to 0.2 micrometer, which cannot be seen by a light microscopy. It has to be stained to see this organism. And it has a regular spirals as compared to the normal treponemes, which are commensals, which has an irregular spiral. This is how you can differentiate it from morphological. Sorry. So coming on to the diagnostics in syphilis, still we don't have any gold standard because this organism cannot be cultured, as we all know. So only things we left is a direct demonstration, that is by the dark ground elimination, direct fluorescent antibodies, and the PCR, which is coming up. But the serological diagnosis remain the mainstay for the diagnosis. So in the syphilis, in the dark, first direct demonstration of treponeme pallidum, the dark field microscopy is definitely the confirmatory. If you find the treponemes in the dark field microscopy, it is definitely a syphilis. But the problem with this assay is that it is cannot be done from the oral or the rectal syphilitic lesions. And the sensitivity of this assay is 40 to 50%. It needs 10 raised to power 4 organism for the smear to positive. You take a color cover slip, put it on the chancre, and you can see the spiral-like organisms. So direct fluorescent antibody, definitely it is more sensitive than the dark ground elimination. You can see monoclonal antibodies are used against this 47 kilodalton antigens, and it can be done from the oral and lesion as compared to the DGI, which cannot be done. But it cannot differentiate between the treponemes and the other treponeme pallidum and other pathogenic treponemes. Here you can see the direct the fluorescent treponemes. PCR for the syphilis. See, PCR can detect 10 organisms also in a lesion, but it is not recommended for the routine use in the blood because a lot of inhibitors are present, and the sensitivity of the PCR in the blood is very less, approximately 20 to 30%. So it is not recommended to be used, although it has been carried out in the HIV patients, and a lot of multiplex PCR and the real-time PCRs, multiplex PCR treponeme pallidum using HD CRY and HSV has been developed in the developed world, and they're using it also. But the cost of the infrastructure also has to be taken care of. So it is not a widespread use in the developing countries, but it can be used in situations in the oral lesions and the rectal lesions, or as well as genital lesions, but cannot be done from the blood. So we have what is left is serological test for the syphilis, which is we have two types of assay, that is non-treponemal test and the specific treponemal test, which is detects specific antibodies. And the non-treponemal tests are non-specific tests because it's detecting the non-specific antibody. So non-treponemal test, it measures antibody directly against this cardiolipin antigen, which is basically derived from the beef heart, and it is not specific for the treponemal pallidum. The titers usually correlate with the disease activity, and results are reported quantitatively. This is the major advantage of the non-treponemal test, that it is a prognostic. You can measure it quantitatively, and you can see the response to the therapy. The main assays, as we all know, are the VDRL, the RPR, the trust, that is tolerant red unheated serum test, and the unheated this USR. So what you can see is if it is a reactive in the VDRL, you can see the floccules like this under the microscope, and if it is a non-reactive, you can see this homogeneous background. This is the kind of, and then you can titrate it. So what are the advantages of this non-treponema test? Major advantages is because it is rapid, easy to perform, and quantitative, and the most important, as I mentioned, it is a prognostic. This is the major advantage of VDRL, because simple, easy, and prognostic. But it can be used to evaluate the possible infections. The major disadvantage is it is insensitive in the primary syphilis, and also not very good sensitive in the case of late syphilis. So sometimes the false positive reactions may occur, particularly the biological false positive reactions are there, and sometimes you get a false negative reaction because of prozone phenomena. Prozone phenomena is because antibody excess is there, and then you can get a negative results. So this is, as I mentioned, that it is a prognostic assay. So antibody starts rising, VDRL antibodies or the non-treponemal antibodies start rising approximately up to 1 week, and then they peak and the 4 to 6 weeks, and then they start falling. If the treatment is given in the primary syphilis, the antibodies will fall in 6 to 18 months, 6 to 12 months. But if it is given in the secondary syphilis, the antibodies will take approximately 18 months to fall down. So as I mentioned that the biological false positive reaction can occur in this non-treponemal test. These are two types of biological false positive reaction. One is acute, and that is lasting less than 6 months, and the chronic, that is more than 6 months. Among the acute, even in the pregnancy, it can be positive. So more than 1:8 titer is taken as positive. And then the spirochetal infections and other acute infections, acute viral and the bacterial infections, and some of the immunization, you can get this biological false positive reactions. And in the chronic infections also, like tuberculosis, the leprosy, malaria, and some of the autoimmune disorders like rheumatoid arthritis, you can get this false positive reactions. So that is why titer of more than 1:8 in VDRL, or this is taken as significant to rule out the biological false positive reactions. Coming on to the treponemus serological test, these are mainly used, these are the specific tests as I mentioned, because detecting the species as well as the genus. It is mainly used to rule out the biological false positive reactions and can be used to confirm neurosyphilis and the congenital syphilis. It can measure the antibody directed against treponema pallidum antigens. It is not quantitative, as I mentioned, and once it is positive, it will remain positive throughout the life. Titers usually do not respond to assess the treatment response. So treponemal test includes the most commonly used assay nowadays is the treponema pallidum particulate deglutation assay, that is TPPA. FTABS is the most sensitive. It was earlier being used, but now it is not recommended because it is a very subjective and also need technical expertise for FTABS to be done. And then the more ELISAs have come nowadays. ELISAs are equally sensitive as compared to the FTABS, and then chemiluminescence immunoassays have come out. So see, FTABS mainly use the intact treponeme, that is whole treponemes, and this TPHA and TPPA and the ELISAs which are used, they are used to purify and sonicated treponemes. And now recombinant antigens like TPN 47, 15, and 17 are being used in the latest ELISAs which are coming up in a big way. So they are more, ELISAs are more specific assay, and their sensitivity is equivalent to that of the FTABS. So as I mentioned that once this treponemal test like TPHA, TPI becomes positive, they remain positive throughout their life. So this is the same antibody response in the syphilis as shown in the previous slides. All these treponemal tests remain positive, and the VDRL antibodies will come down after the treatment. So coming on to the sensitivity of this serological test, if you see the major problem, these assays are very good, no doubt. VDRL, RPL, whole world, including the sensitivity in the primary syphilis is about 85%, whereas in case of late syphilis, also sensitivity is very less as compared to this FTBS and the ELISAs and the DPP. The sensitivity is very good, about 98% and 93%. Even the ELISAs have a 93% sensitivity. In fact, the TPP also has now got a very good sensitivity, more than 90%. In fact, this is shown 80% here. And the secondary and the latent syphilis, all they have a very good assays, whereas late syphilis, the sensitivity of these assays, treponemal test is very good sensitivity of all the assays, except this the RPR is less as compared to the other treponemal assays, where the specificity is very good. So what is a traditional algorithm is mainly, as we all in India and all developing world, they're doing the routine screening by the non-treponemal test like VDRL and the conformity test by the treponemal test. This is a algorithm which is being followed all over the developing countries. But as I mentioned, that the VDRL has a poor sensitivity in the primary syphilis. Nowadays, the synthetic VDRL antigens have come, which has a purity greater than that of 99% and keeps it better. And other kits have come like in the ELISA format, where you can, which are non-treponemal tests, they screen and it is used to screen the large number of serum samples. It is better than RPR to screen large number of samples, but the higher false positivity is there in these assays. So it has a low specificity. And it is not a quantitative assay. We cannot monitor the treatment efficacy. So as I mentioned, the ELISA for the syphilis diagnosis, particularly for the treponemal test, so detecting the treponemal species, have come up, and these are rapid ELISAs. Like this is the NZL-TB has, which uses a recombinant antigens, treponemal pallidum, has a specificity of 99%, sensitivity of 100%. Similarly, this another rapid ELISAs, that is syphilis ICA, which has a sensitivity of 99%, sensitivity of 99%, and uses a 3 recombinant antigens. Both can detect specific IgG and IgM, and both are better than the FTDS. Advantage of this is NZ-well-TB is that results in 1 hour as compared to 3 hours in case of immunochromatographic ELISA. So this is, as mentioned, that this is a traditional algorithm which is being followed. RPR is positive, put another test, treponemal test. If it is positive, syphilis is definitely, and if it is negative, then it is syphilis unlikely. But now the reverse algorithm has come, which is coming up in a big way. The reverse algorithm is that use the treponemal test first, that is ELISAs or the chemiluminescent assays. So if it is positive, then you go for the non-treponemal test, that is RPR or the VDRL. And if it is positive, then it is syphilis, which is whether it is a past or present. But if this non-treponemal test is negative, you can go for another treponemal test with a different principle. For example, you do a TPHA here, and if it is there, then syphilis, if it is positive, syphilis is present, and if it is negative, then it is syphilis unlikely. So this is the reverse algorithm which is being followed. The major advantage of this reverse algorithm basically is used using the ELISAs. The major advantage is that it can detect the early syphilis cases as well as some of the late syphilis cases, and is used in the labs where the automation can be done, because ELISAs can be automated. Large number of samples are there, so you can automate it. So there it is being, reverse algorithm is being used. As I mentioned, that the sensitivity of this reverse algorithm is more in case of early syphilis and detect more cases of the late syphilis as compared to the traditional algorithm, and it can be automated. But the problem with this is a higher, the cost is higher as compared to the traditional algorithm. More follow-up are needed, mainly approximately 3 follow-ups are needed, because if it is positive, if you want to see the prognostic or the response to therapy, you need to have another non-treponemal test. And then sometimes the false positive reaction can occur in case of this treponemal test. So all these points have to be taken into the consideration. So another thing is advantage of this reverse algorithm is that you can lead to the identification of patients with discordant results, like positive treponemal test and the negative NTT test. It can be lead to the false positive results. It can happen in case of false positive. It can happen in case of Rosen phenomena, that is positive TP test and the negative NTT test. It can happen in early primary syphilis or adequately treated past syphilis, or the untreated syphilis of the long duration. So all these are situations where the positive treponemal test and the negative treponemal test can be there. So which algorithm to use? So what is recommended is, it is not necessary that you need to use a reverse algorithm. Definitely detect some of the early syphilis cases, but it depends because it has been seen that the cost has to be taken into the consideration, and the sensitivity of this reverse algorithm is almost equal to that of the traditional algorithm, maybe a little bit more. So it is recommended that it depends upon the local syphilis prevalence. If the prevalence is high, in that cases it can be used, and the workload is high and the prevalence is high, you can use this kinds of reverse algorithm, which is being used in the developed world. And there's a requirement for automation, and definitely, as I mentioned, budget or the cost is an important factor if you want to use a reverse algorithm. So coming on to the point of care tests, these point of care tests are the combination of the treponema, the non-treponema test have come, and also the combination of the HIV and hepatitis C. These are basically using the lateral flow technology or the particular recognition assay or the immunochromatographic assay. These are can give you results in approximately 15 minutes. As you can see in the COVID also, this self-test which is available now, that is in the COVID also 15 minutes you can get this similar like that. So you can, if the two lines are there, it is positive. So similar like this, this test can be done from the blood as well as from the serum. And this has shown, these point of care tests have shown a very good sensitivity. For example, from the Abbott's and this bioline, this 85 to 97% sensitivity and specificity of 95 to 99%. All these tests are available, and even for the dual point of care test, which is the Span Diagnostic India, that also uses the treponemal and the non-treponemal test. But this point of care test, you see, they cannot distinguish between the new and the previously treated cases, and do not provide a non-treponemal titer to the follow-up response. So it is not prognostic. So it has this point of care test has less utility in where the laboratory access is available. So point of care test can be used in situation where the there is less access to the lab, for example, and the prevalence is very high. For example, the ANC clinic, then you can use the point of care test. And in the low resource setting, the point of care test is not only effective but the cost effective as well. So now we have a dual point of care test for the HIV and syphilis, which is also shown a good sensitivity, which is WHO has pre-qualified the assay for the HIV and syphilis. They have shown the sensitivity and specificity for HIV for is 100% and specificity of 99%, whereas sensitivity and specificity for syphilis is 87% and 99% specificity. So these are the available rapid this dual HIV syphilis assays which are available from the SD Bioline, and this is accepted to the list of pre-qualified in this pre-qualified WHO. This has shown a good sensitivity and specificity, and it is being used also in our country. So these are about the point of care test. Now the serology. What are the challenges in serology? What are the situations where some controversial issues are there? The first is sero-fast state. Sero-fast state is that the patient who failed to achieve four-fold decline in the non-treponemal, that is BDR or RPR antibody titer, after the treatment. Even after the treatment, they failed to achieve a four-fold decrease in the titer. So these are called the sero-fast patients. And it has been seen by the various studies that 31% of the sero-fast patient had a CSF abnormalities consistent with the asymptomatic syphilis. So this is one of the problems. The sero-fast patients can have asymptomatic syphilis, but some of the studies have also shown that only a modest proportion, that is 27% of the HIV uninfected achieved the serological response 6 months after the retreatment with the one dose of benzathine penicillin. Means if you give a treatment also, it is only the 27% of the population which in which the serological response is just these in sero-fast patients. So what are the long-term clinical consequences of being sero-fast? Currently the CDC guidelines recommend the additional clinical and the serological follow-up in the sero-fast patients and retreatment if the follow-up cannot be short. And there are situations where the discordant serology is there, another like positive treponemal test, as I mentioned, and the negative non-treponemal test, but the history of syphilis is there. If syphilis treatment is there, then there is no further management is needed. But if the positive treponemal test and the persistently negative non-treponemal entity and the no history of syphilis treatment is present, then these are missed by the traditional algorithm. It can be picked up by the reverse algorithm. So what in this situation, what is the risk of transmitting syphilis actually is very low of these individuals. The risk of transmitting syphilis vertically is also very low. But the progression to the tertiary syphilis in case of ophthalmic syphilis is very high, but neurosyphilis, the progression to is very low in situations where the positive treponemial test is there and negative non-treponemial test is there, and there is no history of syphilis treatment. So what is recommended by WHO is that if there is no history of treatment, these patients should be assessed clinically and treated appropriately if signs or symptoms of active syphilis are noted. And if none are found, it is better to treat the syphilis of unknown duration with 3 doses of 2.4 mega units of the benzocaine penicillin weekly. So coming on to this was about the syphilis, and coming on to the neurosyphilis, which occurs early in the syphilis infection in 30 to 40% of the patients, and asymptomatic neurosyphilis can occur in any stage, whereas symptomatic syphilis can occur after months or years of the syphilis infections and present as syphilitic meningitis, bacillar meningitis, and the meningococcal syphilis. If you talk about the neurosyphilis diagnostic, it is very complicated because there is no gold standard, and the definite diagnosis requires a serological confirmation of syphilis infection at any stage together with the reactive CSF VDRL. And the criteria for the asymptomatic neurosyphilis have not been standardized, which complicate the interpretation of the tests used to diagnose neurosyphilis. So what are the situations in which the lumbar puncture is indicated or the CSF examination is indicated? Is the neurological signs and the symptoms or the patients with the tertiary syphilis, and it is also recommended in asymptomatic patients who are serofast, particularly in HIV patients where the CD4 count is less than 350 and the RPI titer is minus to 32 even after the treatment. In this situation, LP is recommended for the neurosyphilis. So what is the most standard serological test for the diagnosis of neurosyphilis is a CSF VDRL. RPR and is not recommended for the CSF. Only the CSF VDRL is recommended in case of this. And VDRL in CSF is highly specific. If it is positive, no doubt it is a neurosyphilis. Positive results in the absence of CSF contamination with blood confirms the diagnosis, but negative does not rule out the neurosyphilis because the sensitivity of this for CSF VDRL is 30 to 70%. So this is another problem. So which can be solved by the treponemial test, the severe like TPHA or the FTBS sensitivity in CSF is very good, much better than the this non-VDRL. But the problem is you can get false positive detection. It is non-specific. So the clinician take all the picture together, all the inflammatory markers also, along with this test like CSF, the pleocytosis, that is more than 5 cells has to be there in immunocompetent and more than 20 cells has to be there. And the CSF protein concentration more than 45 and CSF glucose is should be less than 2.72. So all these CSF inflammatory markers as well as the test other CSF other treponemial test in the CSF along with the clinical picture has to be taken into the consideration for the diagnosis of the neurosyphilis. Serum in the CSF VDRL is positive, the neurosyphilis is definitely confirmed. But the situation, sometimes the odd situations are there, like clinical suspicion is there, CSF VDRL is negative. Then the FTABS is very sensitive, but avoid contaminating with the blood. Then sometimes the serum VDRL is negative, CSF VDRL is positive. It is very unlikely of the neurosyphilis if it is serum VDRL is negative. So both have to be positive. Coming on to the syphilis, HIV and the syphilis. Syphilis if the syphilis the serological response of the syphilis in HIV patient is very erratic. Sometimes you can get is very atypical. Sometimes you get a false negative results. Sometimes you get a higher than the expected, and sometimes you delayed appearance of the seroreactivity or the fluctuating titers. So it is very dicey. You need to see everything in case of HIV patients. The syphilis, how these treponemial or the non-treponemial tests behave. And the negative syphilis serology with the clinical evidence of syphilis, that is CD4 200, if CD4 count is less than 200, then you get a negative syphilis serology. And HIV can also cause a false positive syphilis non-treponemial test. So all these points have to be taken into the consideration while dealing with the HIV patients with syphilis. Coming on to the congenital syphilis, as we know that we have 2 types of syphilis early, that is the first 2 years of the life, and the late congenital syphilis that is diagnosis after the 2 years of life, with mainly the tooth, bone, and central nervous system manifestations. Definitely, the prenatal screening has decreased the incidence of the prenatal syphilis and death rate stillbirth, and the death rate was 50%. And the initial screening is recommended in the first trimester as well as to be repeated at 28 weeks. And then again at the delivery in the woman at the higher risk. Any woman delivering a hydroptic or the stillborn infant at more than 20 week gestation needs a prenatal screening for the syphilis. And the serology, but sometimes you get a missed congenital syphilis cases, a lot of them, because serological tests performed on the infant serum can be non-reactive sometimes if the mother's entity or the non-terminal test is of low titer or the mother was infected in the late pregnancy. So during this, all these cases, you can get you can miss this congenital syphilis. So congenital syphilis still a diagnostic challenges because 60% of the infected infants are asymptomatic at the birth. That is one of the major problems. And if it is symptomatic, then the non-terminal, there should be fourfold difference in the infant serum titer and the mother's titer. There should be fourfold difference. So then you can diagnose the congenital syphilis. But this fourfold rise occurs only in the 30% of the infants. So this is another problem. But in but you have now ELISAs, IgM ELISAs or IgM FTDs you can do, where you can detect 80% of the symptomatic infects as compared to, rather than if you don't want to see the fourfold rise, because sometimes you cannot follow up these patients. So in case of, but it is sure that non-terminal titers will decrease by 3 months and become non-reactive by 6 months. If they become non-reactive, then infant is either non-infected or it is adequately treated. In case of late syphilis, if the reactive treponemal test after the age of 18 months is the treponemal tests are reactive, then it is diagnostic of congenital syphilis. So I would like to conclude my talk that some key points are there. The direct test helpful in the early syphilis, but the mainstay for the diagnosis definitely remains the serology. The traditional algorithm using the NTT and the TT remains the standard in many parts of the world. Reverse algorithms using the treponemal ELISAs has a benefit of being as sensitive as non-terminal screening test and detect with more cases of early and latent syphilis, but other definitely reduce the labor cost, but other factor has to be taken into the consideration, like the cost and the syphilis prevalence has to be taken into the consideration. Then the point of care test has to be can be used in the resource limited setting where the no access to the lab is there, because it cannot differentiate the previous and the other early and the syphilis. So, and then the reverse algorithm will ultimately contribute to the goal of improving syphilis prevention and the control. The diagnosis of neurosyphilis continues to be challenging, as needs a collection of the CSF for the combination of the entity and the treponemal test as well as the CSF parameters. And the congenital syphilis management still requires an assessment of the maternal treatment and serological response as well as clinical and laboratory investigation of the neonate. Thank you so much for listening.
Thank you, Dr. Sunil Sethi. It has been excellent presentation, very crisp, concise, and complete. Thank you very much.
Thank you so much, sir.
May I have the slide?
Srinivas, third slide. Moderator slide.
Moderator slide. Dr. G. Venkatramana is well known to all of us. He has over 19 publications in STDs and human sexuality. His interest remains in sexology more, with over 576 presentations at different levels. He has been awarded so many things. I request Dr. Venkatramana to take charge of the moderation of the session on treatment of syphilis. Over to you.
Good evening, sir. Good evening, all of you, senior colleagues, friends, and my dear well-wishers. Good evening and warm greetings from Hyderabad. As you all know, lot of challenges have been posed by the beloved speakers. This syphilis is actually described by many people as sexually transmitted diseases with causing major health problem worldwide. It's having a lot of impact on the reproductive and child health through infertility, and causes cancers and causes pregnancy complications also. So our speakers have elucidated how it occurs from person to person. Apart from this, we should not forget two more reasons like infected blood products, needles and vertical transmission, and occupational hazard also. So this clearly shows that infections, in spite of so many efforts by all the governmental agencies, the number of infections across all countries are increasing year by year. And among them, the important key factor here is youth are becoming the major carriers of this problem. The total youth, who constitutes about 27% of the population, are holding 50% of infections. That's a very, very important. Unless we address the youth will be affected, and the entire nation will be affected, because these are the people who are the backbone of the nation, for any nation for that matter. So this syphilis is the oldest first generation disease. Now, as re-emerging as a global public health problem, particularly among a subset of people who practice sex with same men with having sex, that's called MSM group people. There's a very big problem in that sect. And this is morphologically and antigenetically distinguishable by its sisters, namely Treponema endemicum, Treponema keratinum. These are all the other organisms which are going to cause a non-sexual treponematosis. So as a clinician, we should be very careful when you are examining the dark ground microscope, because many saprophytic treponemes we are holding. Our human body, mouth, genitalia will have lot of local resident treponemes, which a experienced clinician can distinguish between this and the pathological Treponema pallidum. So the Treponema pallidum, the syphilitic cases are increasing every year. This I'm showing the statistics from CDC of America. It shows 870 cases of syphilis among the newborns in the 2015 year. So that clearly shows even the advanced countries could not control the congenital syphilis. Still, the vertical transmission is going on, and people are, the pediatric population is still suffering with syphilitic infection, in spite of all best efforts in all the countries. So this graph clearly shows that from 2013 to 2017, there is a 31% increase in the prevalence of syphilitic infection. That's a very, very, very pathetic situation. Among the various subpopulations studied, the STDs infection clinically in the clinics shows advancement of zero prevalence of syphilis is around 2.62%. Again, if you go to antenatal clinics, it is a 0.84%. So still the syphilis is there, but it's there less in the antenatal woman, more in the STD clinics. So the entire prevalence rates in various studies shown in India, this is from Indian study, it clearly shows STD prevalence rate is coming from in clinic to clinic, ranging from max on average 21.9%. So this is the split figures of this STD clinics every year from 2006, 7, 8. They are maintaining somewhere around 4% to 1.39%. Whereas antenatal clinics are always maintaining less than 1%. Again, if you go to HIV positive patients with this syphilis, it again ranging from 3 to 12%. Whereas if you go to blood banks, fortunately, of late, the blood banks are able to maintain zero prevalence. That clearly shows that we are using totally screened, tested bloods. That is a very good positive sign here. If you look about the Indian prevalence syphilis, in the year 2014, totally 32,902 cases of syphilis were detected in India. Among them, 16,000 males and 16,000 females. Whereas it comes to 2015, the female has come down, male maintained again same 16,000. So this clearly shows the syphilis is not leaving us in spite of all best efforts. If you split by state in India, Telangana is holding highest number of syphilitic cases, 9,230. So likewise, followed by Karnataka, Bihar, Andhra Pradesh, Rajasthan, so on so. So all this clearly shows that syphilis is here, going to stay with us as long as we are having infected sexual intercourse. So it is up to the citizens of every country and their governments and healthcare systems to prepare the citizens how to decide how to adapt to these conditions. Now, in order to discuss about these challenges, now let us invite the erudite panelists for this panel discussion. Dr. Yogesh Marfatia, just now you heard, entire nation knows about him. And we Telanganites, we are very much affectionate to him because Hyderabad is his second house. He is the one who inaugurated our Telangana Bhavan, Telangana IADL Bhavan. Welcome you, sir, Yogesh Marfatia, sir. Give him a big hand, please. Then V.K. Sharmaji is a well-known person, well-known personality, plenty of books and chapters and many medals for his credit. Now he is currently Dean and Academic Affairs of the Sharda Institute of Medical Sciences. And Hanumantaya is senior most man. And now he is working for Kolar Medical College. Welcome you, sir. Sunil Siddhi, just now we heard him. He is now is a Vice Chair International Union of Sexually Transmitted Diseases, and he is Vice President also, awarded ICMR International Fellowship. And to his credit, he has 120 publications. Welcome you, sir, Dr. Sunil Sethi sir.
Thank you, sir.
Rashmikant Shah, he is the current Vice President IADBL, and he is a well-experienced man in the leprology. Presently, Council Member of Asian Dermatology, and he is having very many publications for his credit. We welcome you, sir, for this panel discussion. Rashmikant Shah, sir. Our young Turk, the Turk of Telangana, our Thakur Rajiv Singh, Professor and HOD DBL Usmania, young dynamic person among our TSIDBL. Welcome, Raju. Welcome for this panel discussion. Now, I am posing the cases that have come to me, refer to me, so that we can discuss for the benefit of all junior colleagues here. One of my 38 years male HIV positive, hepatitis B positive patient who is on treatment and well under control. Hepatitis B viral load is undetectable. HIV viral load is undetectable. CD4 count is more than 700 when I saw him. He was a diabetic smoker but non-alcoholic. He developed penile ulcers and seen by local practitioner who gave daily injections for 10 days but no response. Then he came back to me. On history taking, he admitted that he had a sex 3 times outside, developed ulcer after a month. Nature of injections are not known, but the history reveals that the practitioner has charged 100 rupees per day, has given injection for 10 days. So I presumed that it may be a placebo injection or maybe any low dose antibiotic. On examination, the ulcer is irregular and is healing. Subtle pain was there on palpation, no adenopathy. Rest of the examination, other mucous membranes, physical systemic examination was normal. Now I request our dear panelists to throw some light. Now this is the ulcer that the patient had. Now we'll go to the first speaker panelist. Dr. Marfatia Saab, are you there?
Yes, I am very much there.
Yes, sir. Can you throw some light here? How to go about this case?
Yeah. So as reported by you, the history is positive for exposure and ulcer is there. So yes, and it is mildly painful. So yes, clinically first I will consider syphilis, but it has to be supported by diagnosis. So what is available at our center is VDRL and TPH. I will go for that. And then of course, I will try to give treatment of first choice, that is benzathine penicillin. And secondly, one has to keep in mind his HIV background and hepatitis B background, particularly HIV background because of the potential early transmission towards neurosyphilis.
Excellent, sir. So our juniors should know that whenever there is a background of HIV problem is there, one has to be careful, exclude asymptomatic neurosyphilis. We will take the inputs from Dr. Sunil Sethi sir. Sunil Sethi sir.
Sunilji, unmute.
Unmute.
Yeah.
Yes, sir.
Sir, I have not gone through the questions. Some phone came. I'm sorry. What is the question, Madam?
Then we will take your inputs for next case. Now we'll go to Dr. Hanmantaya.
Okay.
Hanmantaya. Dr. Sharma sir.
I think Doctor already has highlighted that we will go for syphilis, diagnosis and treatment. And he is HIV positive. So we already have a concern whether the test will be positive or negative. It can be weakly positive in HIV positive patients. VDRL can be weakly positive. And patient had ulcer. He had 3 contacts. So he already having multiple contacts. So the possibility of other ulcers also should be kept in mind. Now it does not look like granuloma inguinal. It does not look like that from the picture, but we need to watch out the response to treatment. The response to treatment also sometimes may not be as good. It may take little more time in HIV positive. If possible, we should get simultaneously CD4 count done so that we know how to go for the future management. I already have a patient in my ward who is HIV positive, hepatitis B positive with the Stevens-Johnson syndrome.
Sir.
So we are investigating and assessing. So this is very relevant point. Yes.
Yes, it is true. Because of the HIV status, demonstration of dark ground examination, because patient is already treated by local practitioner with injections, and that because of that also, the chances of demonstrating treponema pallidum will be very, very weak here, very meager. So our diagnosis more relies on the serological test only. So these serological tests at the background of HIV, one has to analyze them. It is a real challenge for the treating physician. At the same time, as rightly pointed out by V.K. Sharma sir, if the latest CD4 counts are viral loads, the viral load is high as CD4 is low, then we have to exclude asymptomatic neurosyphilis. That should be mandatory. Number 1. Number 2, there is response to single dose of benzathine penicillin is very unlikely. We have to watch and give multiple doses.
And we also may start antiretroviral therapy.
He's already there, sir. He already there. When I saw long back, he was well under control. Now I have to re-evaluate the present situation. Accordingly, I have to treat him. I have to titrate the treatment. Right. Any other person is there? Dr. Rajiv, are you there?
Sir, the two important aspects is, sir, I'm sorry. Sir, we do not have a CD4 count here.
Hey, we have to do now. We have to do now. That's what I'm telling.
CD4 count is not available, and then syphilis. I mean, the ulcer of duration is not mentioned, sir.
Is there?
1 month.
Is there?
3 times exposure. Then what is the duration that last exposure he has developed?
After 1 month, he developed the ulcer.
Right, sir. Then. But demonstration of DGI, I mean the spirochetes may not be possible, or what kind of infection was taken, but we have to go by preliminary investigations of DGI first, because ulcer is available. Ulcer is available.
Yes, that's why I'm telling it's a challenge for the treating physician.
Correct. So we have to demonstrate a spirochete by doing a DGI, because an ulcer is available and the positive factor being present at the coronal sulcus.
Yes.
The only negative factor here is it is painful, though not secondarily infected as it appears. Obviously, it is purely an erythematous ulcer. It is not secondarily infected, though it is painful.
We don't know whether it is infected or not, because I already taken the injections daily by his practitioner.
Correct. Sir, but the pain.
Yeah, pain also,
But-
subtle pain is there.
Yeah, subtle pain is there. Yes. Yes, sir, it is a challenge. Yes, sir, it is a challenge.
Definitely.
Except for, yes, sir, it is a challenge.
The total panel discussion is of challenges only, not
Correct.
a straight cases.
Correct.
This is for challenges so that we
But
can
with
train
HIV
up.
infection, it will be painful.
We can train our juniors to face these challenges.
Correct.
The main motto of this panel discussion is to train our juniors with all our senior inputs.
Sir, can I add
Yes.
one
Yes, sir.
sentence?
Yes, sir. Hanumantaya, sir. Yes, sir.
First and foremost, he has taken 10 days treatment.
Yes,
Let us respect that particular local physician whoever has given. It means the ulcer has partially healed. So it
Yes, sir.
means if it is partially healed, even now also it is persisting and the surface is having a purulent discharge. So it means it is infected. So this infected, we have to take it as whether it is a staphylococci or streptococci, other than our regular STD organisms. So it should be treated as a mixed chancre, sir.
Shankar only, sir. Yes, sir.
Yes, mixed chancre.
Sir,
Now
here would we do a reverse algorithm or a standard algorithm for the testing?
Yes, usually of late WHO and CDC recommending reverse algorithm is only because where
that's
the
what I wanted to tell my juniors,
Yes,
reverse
in Apex
algorithm.
centers, in all medical college centers, we have a facility of doing treponemal test as well as non-treponemal tests. In such centers, reverse algorithm is the best method. In peripheries, where the treponemal tests are not available, then we are bestowed with only NTT, non-treponemal tests only. There we have to rest upon rising in titers. Response can be assessed by for decreasing in titers by 2 tubes, that is 4-fold decrease. So these are again a challenge. This all depends upon the experience of the treating physician. Yes, Murugan wants to add something. He is very.
Dr. Venkat.
Yes.
Shall I see the picture once again? The floor is not a ham color. It is a more necrotic. That is a yellowish. Could it be a mixed chancre or chancroid? Why you are not suspect a chancroid? Chancroid also will be like irregular ulcer, pain, tenderness is there. So that is also
Correct. Sir, let me tell you one thing, sir. Let me
can
speak
be
about
known. That problem will arise when we are unable to demonstrate treponema pallidum, when the low titers of the non-treponemal test will come, then we have to suspect that. Because now we are in the evaluating stage only. We have not done the dark ground. We have not done the serological test. Clinically, we have to suspect all these things.
Yes.
Clinically, a mixed chancre from Hanumantaya, chancre from the history, and chancroid from you, and bacterial infections of somebody, traumatic infection by some other person. It can be anything.
Sir, the other factor being the fusor spirochetes which are present in a situation of a chancroid, maybe that he has developed a mixed chancre or a chancroid it is, which is not getting red because of daily injections of penicillin could also be a cause. And that could also be a factor here. Though he is taking probably penicillin for the last 1 week, it is just the fusor spirochetes are getting red, the H. ducrei remains, and the situation prevails. That is also the other possibility.
All these possibilities will be, Pandora box will be opened.
Yes.
When we fail to demonstrate treponema pallidum.
Sir, the other factor is, could we not give a cotrimoxazole tablets? I mean, a Septran simple and then check, because it is not going to be it is a non-treponemal drug. Can we have an approach in this fashion?
Correct approach.
That approach is already, we have wasted 1 month now, 1 month, 1 week. Now, if you are again doing a trial, it will be wasted, because if it becomes a syphilitic infection, HIV positive, unnecessarily time is wasted. It may be enter into asymptomatic neurosyphilis.
Sir, I would like to tell you one thing is like, generally we follow up this kind of a patient for one year. after giving treatment of syphilis.
Yes, sir.
But because of this HIV, we need to screen him for 2 more years.
Yes, sir. Totally 2 years we have to screen. We have to follow up.
2 years. And
Yes, sir.
anything rising more than 4-fold, then the last, this thing should be considered as a recurrence.
Always fall up to 4-fold or rise up to 4-fold has to be significant. That is very much needed. So this is a real challenge for the juniors, right? So we have to go for demonstration of treponema pallidum, then serological tests. Based on the titers, we have to treat. If the titers are low, non-specific or specific treponema test is negative, then we have to think of chancroids or think of other traumatic infections. So this is a real challenge for the treating physician. We'll go to the next case. One young 29-year male patient came to me in panic, saying that this is every STD specialist will face this problem in India. Sir, I am going to Kuwait for job. Got visa. Went for medical examination. They rejected me saying that my TPHA positive, VDRL reactive. I thoroughly examined. He is clinically asymptomatic, but admitting sexual encounters in his town. He denied any ulcers or fever or arthralgia or skin rash in the history. But he says he used a lot of antibiotics of late because of corona as a precautionary, as advised by his doctor. Then I subjected him for serological tests again. Yes, TPHA is positive. VDRL is 1 in 2 dials positive quantitatively. Now, how to go about it? Panelists, now again, I will start with Vinod Kumar Sharma sir.
Sharma? Yes. Sir. Yeah. So this is a regular situation.
Yes, sir.
And we need to reassess the person, carry out the VDRL TPHA under your own supervision. In the end, patient will ask for a certificate that whether he is infectious or not.
That is ultimate.
So you need to carry out the test and sometime even treatment under your care.
Yes, sir.
All the penicillin injection may have to be administered so that you can write down it was administered under my care.
Yes, sir.
And patient has no active infection. In the end, we can say.
Yes, sir.
So
Yes,
the
sir.
blood test you will order is again VDRL TPHA, which already has been done. And the positivity is very low. So it is likely to be a zero-fast patient. And he still may not get visa. After our certificate also, sometimes they still don't give visa.
Even if you give certificate, people are not honoring that.
Yeah.
They will not honor.
Yeah.
So we only used to give a certificate. The patient has been evaluated in detail.
Same thing. We are also doing
tests were
same
carried
thing.
out. He has been given treatment under supervision.
Yes.
And after 1 month or so, we could say he is currently non-infectious and can travel.
Yes.
Something like that.
Yeah, yes, sir. We are also doing same thing. We used to give certificate saying that he has taken full scientific treatment. Now he is non-infectious. That a specific test TPHA will never become negative. That will be there, but it's not an indication for any active infection, not a sign of active infection. This is for information. Right. That's how we used to give.
Right.
So now for here, as rightly said, PDRL is 1 in 2 dials. It may be because previously would have been higher, maybe responding to the treatment because of his a lot of antibiotics he has taken for corona. Happenstance treatment might have occurred. Or as you rightly said, he may be in the low titers for the last zero fast patient, or maybe asymptomatic syphilitic infection. Still may we have to watch carefully whether rise in titers occurs or not. So now 3 scenarios can occur here. We will go to Rajiv. You want to throw anything?
Sir, this TPHA positive for the patients who go abroad, especially to Gulf countries, are done at specific places only, and only from these places they are screened and being given a visa. No,
Yes, sir.
there is no way that you can get rid of a TPHA positivity in any scenario unless this patient is co-infected with HIV. The only thing he can get rid of TPHA positive is he has to concur with the HIV infection. Then only you can get rid of TPH. that is my suggestion to the patient.
No.
No, I think we need to simultaneously do HIV testing also.
Yes, sir.
Because anyway, it would have been done before also if he's gone for visa.
Yeah, yes, they did it only because of TPHA positive, they rejected him.
So I think in such a situation, our association can write to concerned authority that this is the standard statement. I think you have made a nice paragraph on that. So that this statement is also given by our association. So this certificate,
Yes, sir. This is
they can attach it with
because
that.
this is a very thoughtful happening for every STD specialist. People will come, they are referring to us, people are coming here, we are making them non-infectious, but they are not allowing him to go for his job at Middle East.
Yeah.
Sir,
That is the problem.
I remember one patient who had taken 12 injections of penicillin at different places.
Sir.
And he was not taken up because
Yes, sir.
CPHA always remained there.
Remains positive, that is the problem.
He has taken 12 injections of this thing.
In the visa counter, all the people are non-medical people. They will not accept whatever certificate you are giving. It will not be counted.
Yes, they won't honor. I have interacted them, and the only answer what they get is, sir, if we honor it, we lose our licenses. So that center will not be recognized by the Middle East recruiting authorities. That's why they are afraid of it, because they are running it for commercial use. They will get some money by sending these people. That income they will lose. That's why they don't want to take that risk.
And there are so many applicants, they can always find another person who is VDRL negative.
Yes. Right, sir. The next case.
Can I say something, sir? Can I say one thing?
Yes, sir. Yes, sir. Please. Yes, sir.
Sir, I am Dr. Hanmanta. Can I tell 2 sentences, sir?
Yes, sir.
Number 1, syphilis is a simple infective condition. For that infective condition to be diagnosed serologically, the plasma cell has to secrete the immunoglobulin, so-called IgG and IgM. When we are 100% with accuracy, we treat the infective condition, then plasma cell has to stop production of IgG and IgM. For this plasma cell, who is the controller? The controller is CD plus T lymphocytes. Here in this particular case, CD8 plus T lymphocyte has failed to suppress plasma cell to produce IgG and IgM. During this time, if we are 100% convinced full antibiotic course is given, then we have to give a short course of steroid so that it will suppress the active plasma cells. Then production of IgG and IgM are stopped. Then automatically at the end of 45 days, TPHA will come negative, sir. This is my opinion, sir.
For that, any evidences are there, sir? Any reference studies?
Sir, if you go through all any infectious journals, sir, so this is a beautiful explanation given in all microbiology and immunology journals, sir.
Then it's a very good point. Then it's a very good point.
It is one of the learning point.
Definitely very good point. In that case. So that we can bail them out. All these people, we can bail them out.
Without study, we cannot accept. We have to study. We have to make
yes.
No,
that's what
this is not so simple. There are memory cells which are continuing to, or there is a persistent antigen. There are 2 things. They are continuing to stimulate the cells to produce antibodies. There may be antigen persistence, and there are memory cells. So they keep the memory alive. And switching off with 20 or 30 milligram prednisolone may be possible in few patients, but not in all of them. I am sure. We give so much steroids to pemphigus.
That's why I asked references, sir. That's why.
Can I say something, sir? Can I say one thing?
Yes, sir. Bhushan, sir.
Yes, sir. One is that what VK says that it is definitely not a kind of a treatment recommended.
Yes, sir.
we don't expect the antibodies to go down. The other is when we are saying TPHA positive, please see that the cutoff point is 1 in 80. So
Yes,
1
sir.
in 80. So that is one.
Yes,
The
sir.
second is that in this patient, yes, everybody knows that he must have gone to so many places, got so many injections
Yes, sir.
of penicillin or any other thing, and higher antibiotics also. Please exclude any other reason for the possibility of a low VDRL titer. So we are only focusing ourselves on syphilis because he wants to go abroad and something. We may be missing out some presence of another disease in him. So
Yes,
please
sir.
make
All
sure.
false positives also we have to exclude here.
Yeah.
Because
Thank
of low
you.
titer.
Yes, thank you.
Yes, sir. Thank you, sir. The next case is one patient of 20 years age was brought to me by her parents saying that Dr. Saab, of late she is not eating properly, not mixing with the family members, always wants to be alone in her room. When we searched her room, we found one doctor's prescription showing that diagnosis of syphilis and advising benzathine penicillin. Then I talked with the girl with absolute privacy and confidentiality. It came out that, yes, sir, I took that injection, but my VDRL titer is not coming down. My doctor is upset and telling me that my syphilis is not responding to treatment. And he said that is a tough time for me. Hence, I am terribly depressed. Now, how to bail out this patient? We'll take the opinion of Dr. Bhushan Kumar, sir.
Thank you very much, sir. First thing is, I do not know what is the titer. Number two, I do not know what is the history.
Yes, sir.
Because exposure may have been there, may not have been there. And
we have to presume because it is there and VDRL.
Yeah, no, some other non-specific symptoms may also push a doctor to go for VDRL and something in a young girl. So without the complete history, it is difficult.
Sir. Hello?
Yeah.
Hello? Then we'll go to Dr. Marfatia.
Yes, so here, see, the most important thing to reassure her is series of VDRL report. If we don't have baseline, then we should go for fresh VDRL with titer, and then some time is required to document. With document, you can convince her if the titer goes down, because resistant problem is not there, and of course TPHA is also required. So that I think VDRL and TPHA at baseline, and then follow up VDRL. And it will take some time, of course, to reassure her.
Yes, sir. And another thing you have to assure here, we have to verify here is the dose of benzathine penicillin the doctor has given to her
must be low.
Yeah, that is another reason we have to exclude. We have to.
We need to know even if it is latent syphilis also.
Also.
If it is latent syphilis, probably benzathine penicillin require is more.
Number two,
maybe once weekly for 3 weeks.
Why the titer is not coming down? The total crush here is titer is not coming down. So the doctor get perplexed and he transferred his anxiety on the patient, saying that it is tough time for him.
The doctor should be educated first. He should not make her, because it will take time, 6 months to 9 months to become non-reactive. All these things should be told to the patient initially. That doctor has to be educated.
Doctor conveniently has transferred his stress onto the patient. Now patient is entered into depression. So
are we dealing with a patient of primary syphilis, or we are just only treating the VDRL positivity?
That we have to
syphilis reflected through VDRL positivity.
No, how much is the dilution?
That we have is there. VDRL in dilutions is there in the slide here. Because I am unable to read because of this our photos coming here on the right hand corner here.
I can't see it.
Yeah, same thing.
You're right.
So here the titer is not coming down, maybe because of we have to wait for some time and see whether it comes down or rises. Even not rising in titer also is a good sign. Whether maybe going for serofast.
Maybe it is a false VDRL positivity.
That's also there.
So
But of course, it should be a low titer then.
So these are all the intricacies, challenges, which as a treating physician one has to face. Thank you for all your inputs. So
Sir, one sentence.
One, we have to train the doctor that wait patiently. Don't transfer the doctor's anxiety over the patients. Doctor has to be counsel and soothe the patient's anxiety.
Sir,
we should not transfer it. Yes, sir. Another sir.
There are two things. One, here patient is not mixed with the family members.
Yes, sir.
So it means we have to take care of the family members also. Family counseling is 100% essential, number one. And if necessary, we have to take the help of psychiatrist to guide this particular lady.
Yes, because she is in a depression. That's why she is aloof. Parents are worried that's why they searched the room. They searched with the intention of any suicide note. But the doctor's prescription with injection benzoyl penicillin came out.
Yes, sir.
Right, we'll go to the next case, sir. One 30 years full-term pregnant woman came to the labor room with pains, labor pains. She doesn't have any antenatal checkup records because 1 month back only she came to her parents' house. Today got labor pains. Due to obstetrician, after examination, posted her for cesarean. Blood sample were sent for sugar, electrolytes, VDRL, tridot, everything. And report came out as VDRL reactive. No titers are given, VDRL reactive. Rest of the all tests are normal. Now, tell me how to proceed with this. Immediately the obstetrician has telephoned me. Now, how to go about this? Yogesh Marfatia sir.
Yes. I think the first thing is we have to check her regarding her behavior, risks related to behavior, either she or husband. So that is the first important thing. And secondly,
now the patient is in labor pains. Now we have to urgently we have to answer them.
In that cases, without taking a chance, I am in favor of giving her an injection of benzoyl penicillin and then of course follow up of newborn for congenital syphilis.
Yes, sir. Yes, sir. Then we have to take the history of the husband, parents, everything. Will do that. Now, because the patient is right now in labor pains, we have to treat her and subject her for cesarean section. Then follow antenatally. That we will see this with the rest of the panelists. Now we'll go to Bhushan Kumar, sir.
Sir, I do not know the VDRL dilution, but as Marfatia says, injection benzoyl penicillin to the mother immediately. And when the child is born, the child has to be treated.
Evaluated.
Treated, definitely mandatory, not evaluation. Of course, we will take the blood for the VDRL. That's a different thing altogether. But we will treat the child, the infant, with penicillin.
Yes, sir. Yes, sir. Yes, sir. So here is always now the mother should get the treatment, then go for cesarean section. Since this treatment may not go sufficiently to the infant, that's why infant after birth has to be evaluated and treated full treatment with the penicillin.
Yes, crystalline.
Right. The next question is, one female patient of 19 years referred to me from her gynecologist. She is having one ulcer on foreshoot area. She had sex with her boyfriend only. Gynecologist has examined and asked for a VDRL test. That evening report came as non-reactive. And he referred to me, Venkat, you take care, VDRL negative. Then how to go about it? 19 years old girl, history of sexual experimentation, a single ulcer in the foreshoot area, VDRL negative. Yes, we will go to VK Sharma sir. Sharma sir is not there. Hanmantaya sir?
Yeah, he's there, he's there. Sir, unmute.
Sir.
Sorry, we start from beginning. It's a new case for us, so we will take full history.
Yes, sir.
And whether it is a single sex partner, multiple sex partners,
yes, sir.
duration of the ulcer. Since it is very short time, VDRL can be false negative because
Yes,
still 5-6
exactly.
days only.
Exactly. That we have to keep in mind.
Yeah,
It
keep
may,
that in mind.
It may be a seronegative primary chancre.
Yeah. So,
yes,
and second thing is for PGs, it is important to know that what other tests can be done. FTA-ABS is generally not available these days.
Yes.
You might have to do TPHA. If FTA-ABS IgM is available, it can be positive in early stage.
Yes, sir.
And the second thing also keep in mind whether it is a traumatic ulcer because it is
Exactly.
So, and so that is another possibility to be kept in mind. So we keep a positive approach. Do not make the person too much depressed.
Yes.
And so what treatment you will give? I think that still is a problem because
now the question here is
depend on the clinical examination. If it is an indurated ulcer, you will still give penicillin.
Yes, sir.
If it is not indurated, is it like herpes? Is it like something else? So that we have to see and examine.
In view of HIV positive, this girl is not tested. If it is HIV positive, induration is not a mandatory. Non-indurated also has to be taken into consideration.
Right.
Here,
so,
the challenge is establishing the diagnosis.
Right.
In this particular case. So single.
Can we do a VDRL test and examination of a partner also?
Yes, sir.
That
yes, sir.
would also possibly say one positive point.
Our gynecologist did VDRL. It came negative. Then she said it may not be. Let go to Venkat. He will take care. She referred to me. That's why now the question here is whether this VDRL non-reactive is because of the seronegative chancre. We have to wait for some time and do, or it is a traumatic ulcer, or it is not done properly,
or any other non-syphilitic STI.
Yes. So these things we have to elicit.
Can I go? We can go for a TPHA test in that because
Sunil sir, Sunil say this up. Yes, please.
I think so. We can go for a TPHA test because VDRL, as Dr. Sharma said,
yes. Reverse algorithm will work here.
Yes, and this reverse algorithm will work.
Here. That is the idea.
TPHA becomes positive so fast?
No, FTA-ABS.
FTA-ABS test has to be done.
Yes. Go for FTA-ABS.
Right, sir. We'll go to the next case.
First of all, we want to give an antibiotic. It should not be erythromycin and doxycycline, amoxicillin, and so that will mask the syphilis.
Yes, sir.
No, sir. Yes. One simple thing is, sir, that we were waiting for the results. You can order as many tests what you want, but primarily the patient has to be treated on the basis of a clinical suspicion.
Yes, sir.
The rest of the things will follow.
Yes, sir.
Yeah, patient will leave your clinic after getting the treatment only. So that part is very clear. So you will end up giving a genital ulcer algorithm, syndromic management, give the penicillin and give the second part also. By the time they come back, you can interpret later on.
This is more or the next case is more or less straight case. A 28-year-old male came to my clinic complaining of sore throat for 3 weeks. On examination showed there was a multiple erythematous macules and erosive spots in the hard palate. Cervical lymphadenopathy was present. Characterized by indolent to 2 rounded asymptomatic lymph nodes bilaterally. Also reported concomitant appearance of lesions on the palms. As well as on scaly lesions on the soles also. Not complaining of any symptoms such as fever or myalgia. Sex with only wife. No extramarital sex. Medical history was uneventful. He was neither a smoker nor a habitual consumer of alcohol or beverages. So this is the clinical photographs. This is a more or less straight case, but only thing here is he has not done any sexual experimentation. He had sex only with the wife. Patient landed. Patient landed with secondary syphilis. Now here, the treating physician has to take wife into confidence and elicit the history and treat both. All the cases, not only this case, we have to stress all the cases. Unless the partners are treated, treatment is not complete.
Partners are examined, investigated.
Yes. From where the infection this patient has got, to whom the infection has been given. Unless we complete the circle, the STDs will be increasing year by year in spite of all efforts, which I initially spoke in my initial slides.
Yes.
So this is the problem. Right, so the next case is one woman of 32 years with 1 year child came to me saying that, please guide me properly as I am in deep tension. I had affairs and sex apart from my husband. My son is 1 year old. Of late, not taking proper feeds or milk. Always running nose. Feeling weak. When I Googled, it is telling that it is a congenital syphilis. I am terribly upset. Then all panelists, how to help this patient?
This Google doctor.
Google doctor has come now. He has thrown a challenge to us now.
Yes, submit.
Bhushan sir.
When we are saying a problem of more than 1 year,
yes, sir.
The child is 1 year. So
yes,
some of the evidence of congenital syphilis and some sequelae should start appearing.
Yes, sir.
Which definitely can be identified, if not by the dermatologist, by the pediatrician.
Yes, sir.
The second thing is investigation. Just send her blood and send the child's blood for VDRL. That's the only thing. But as you said rightly, this is more of a Google diagnosis, and everything else has been going on well.
Now, of late, this has become a fashion nowadays.
Yes.
All these educated people, before coming to the doctor, they Google, they will form one opinion in their mind, then they will come to us for second opinion.
Right.
That is a real challenge for us. This lady may be having affairs, but she never suffered. The child was 1 year hale and healthy. Of late, it developed to be not taking proper feeds. Maybe because of simple flu fever, simple viral infection.
Yes.
She Googled and Google has given a bombarding diagnosis, and she is throwing a challenge to us, all of us.
Right. And we presume that all the women who are going to deliver in a hospital or somewhere, VDRL is mandatory.
Yes, sir.
So before the delivery, if she has gone to a good private clinic also, or maybe a government hospital, VDRL must have been done.
Yeah, definitely.
If there was something, she might have been treated. If there is a history of that kind of a thing.
So here in this particular case, more counseling is needed rather than evaluation.
No, but pure counseling also, because you have to put 2 and 2 together. If you simply say out of guesswork that everything looks normal, but the question remains, she has a doubt, which you have also to.
Yes, we have to clear that by counseling and by evaluation.
On the basis of outcome of the investigations only, we can counsel.
Yes, sir.
The previous slides, I would like to comment one thing.
Yes, sir.
Like the patient is in deep tension and a multiple sex partner. So just to relieve her tension, can we get the TPHA done of the patient, of the mother? And if it is, make her tension relieved, you know.
You have to test.
Yes, sir. Say, for example, mother is positive. Let us take it like that. Mother is positive. Fine. Child 1 year old never suffered anything clinically.
Yes.
Now, of late, difficulty in taking feeds, running nose.
Yeah, of course, yes. That is not the symptoms of congenital.
Yes. We'll go to the next case.
As per Profita's law, the symptoms may not be present at the time of birth, but it cannot remain asymptomatic till 1 year. That's also there.
No, it's up to 6 months maximum.
Yes.
Maximum 6 months. One patient who came
Sir,
to me
what is
for,
the take home? What is the take home message of the previous slide that regarding child?
in that case, now we have to counsel the patient and re-evaluate whether there is a real infection in the mother, whether there is active infection in the child, or is simply because of the seasonal or local infections.
Allergic rhinitis.
Yeah, it can be anything.
And where did she deliver, and was she tested before the delivery for VDRL, which is mandatory?
Yeah,
and what were the results?
If the antenatal records are available, hospital records are available, fine. Or else we have to re-evaluate now and come to conclusion.
I think the person who had gone to Google will require blood test for VDRL, TPHA, HIV,
yes,
and
sir.
child also require basic test because they will not rest till this is clearly ruled out.
Yes,
they
yes.
will go to another doctor and
Yes.
it will not finish there.
Yes, yes. They will build a lot of big file going to doctor to doctor, going to door to door. The next case is one patient who came to me for genital ulcer. I take history and physical examination, lab test, and confirmed my diagnosis of primary syphilis. I advised him injection benzathine penicillin 24 lakhs after test dose. Here the challenge is patient is not willing injection. Maharpati sir is there?
Yes, yes. So
Yes,
I
sir.
think I'll definitely discuss with him the advantages of why benzathine penicillin is the drug of choice. That should be discussed with him in a certain terms. But if he is not very keen, then the second line drug like doxycycline, I will prefer to give him 1 BD for a month and a regular follow-up, of course. So, I mean, first again, re-emphasis the role of penicillin, and if not agreed, then only second line drug like doxycycline I prefer.
Right.
In primary syphilis or a chancre, you can give 2 grams of azithromycin stat also, if not doxycycline, which is to be given 20 days.
Azithromycin of late not recommended because of the lot of case reports are there showing that azithromycin resistance. Of late, the documented thing is doxycycline, lamicycline, or plain erythromycin, if at all needed, particularly in pregnancy cases where allergic to penicillin or refusing penicillins. Here the question is, patient is bluntly refusing, then we have no other option other than counseling him for the penicillin. If he still refuses, we have to give doxycycline. But one thing as a treating physician, we have to remember, when we give doxycycline, we have to monitor him carefully for longer times. That is the only hitch here. The challenge here is for treating physician.
Sir, erythromycin base is still recommended by CDC.
Yes, sir.
In
Yes, sir.
certain situations, yeah.
Yes, sir. Yes, sir.
Okay.
The next question.
Sir, one sentence, sir.
Sir.
Sir, we have to give minimum of 21 days doxycycline. The reason is we have to remember Dr. Eagle's rule. The trypanosome pallidum is such a wonderful organism. It will try to secrete salicylic acid around it, and at the same time it make a lot of fibrosis. If continuous 21 days doxycycline or any other antibiotic is there, then only we can kill the trypanosome pallidum. So that is the reason we are giving injection benzathine penicillin. If not, doxycycline for minimum 21 days, sir.
Anything more than
that is the CDC recommendation. Nobody is challenging that. 3 weeks is the CDC recommendation. But erythromycin base is not for the 21 days. It can be maximum 7 to 10 days.
The reason why 21 days means it is the Eagle's rule. The organism secretes salicylic acid around it. It will not allow antibodies to reach, and it will secrete such a heavy fibrosis. The antibiotics also will not reach. If within 20 days, if it doesn't come out of this cavity, automatically it will die. So that is the reason CDC has recommended this 21 days, sir.
The next challenge here is In my online practice, one patient asked me through online, sir, I recently delivered a child 1 week back. I was treated with injection benzathine penicillin 24 lakhs before delivery. My child is having VDRL 1 in 2 dials positive. Please tell me whether my child needs a treatment. Again, real challenge. We'll go with BK Sharma, sir.
Sir, you have 5 minutes. Last 5 minutes.
Last 5 minutes, huh?
Okay.
Here now the thing is
take the audience questions also, which is there in chat box. What are uncovered questions, please?
Here we have to take the mother's titers and child titers. We have to verify whether the child titer is more than the mother's titer or not. If the child titer is less than the mother's titer, it is not the passive antibodies. So one has to assess this. We have to keep in the mind.
Well, in this 1 in 6 deletion is wrong. 1 in 6 deletion is not there in the VDRL.
Yes, yes, sir.
Yes,
that
sir.
is another
It
thing.
is highly objectionable. Yes, at the prima facie only it is dismissed.
I am waiting. Anybody who is going to point it out or not? Yes, thank you very much. Always remember the VDRL dilutions will be doubling dilutions. All general practitioners will do. A lab people will give like anything. 1 in 12, 1 in 6, 1 in 7. They will give like anything. It is we that experienced physician can pick up this and interpret it. Thank you, sir.
One thing, sir. If the benzathine penicillin was given less than 4 weeks before the delivery,
yes, sir.
Whatever is the titer of the child has to be treated fully.
Yes.
So I do not know the history. So, and of course, what is the titer of the mother? But benzathine penicillin given
we have to take the mother
less than
titer.
4 weeks, less than 4 weeks before the delivery, the child has to be treated.
Yes. The next question here is, one gynecologist has referred a female patient with repeated abortions. Both wife and husband went for VDRL, came reactive for both. Wife's titer is 1 in 16 dials. Husband titer is 1 in 8 dials. Wife is pleading innocence. Husband is blaming the wife, and the wife titers is higher than my titers. Now it has become more a family issue. Now, how to solve this issue?
It's an immunological problem.
Well, I think
Sunil Sethi will go to Sunil.
I think this titer can be repeated because one dilution will not make any difference. It can be a technical error also. So 8 or 16 will not make difference. It can be this test can be repeated.
One area, okay, we can repeat the test. Next area, one possibility. Yes, we can repeat it. If it comes again, wife's titer is more than the husband's titer.
Individual body reacts differently.
Yes.
One.
That is one thing. Another thing is, if the husband is little late, is going for late, dilution will be lesser.
Is he treated?
Possible.
Husband might have got treated outside. Now he's taking the defense of this VDRL titer and pestering the wife, taking the revenge on the wife.
The husband is more than 2 years late syphilis, also that will go. That's something.
So here it is a real challenge for the not for treating the infection. It is saving the family here. This case took me for 3 months to solve this case and to give counsel and to save this family. Okay, now since already time is over, our Bhumesh has given me a warning bell. Thank you very much for your contributions.
Any questions from the chat box which I have not covered?
Yeah, please, we are in the pandemic, COVID pandemic. Please practice SMS. Now, any questions there? Please read Bhumesh from chat box.
In the chat box, it is there, sir. Just chat box. Chat box.
We'll go to chat box. Let me close my chat. This one.
From Dr. Ramya, after giving treatment for syphilis, when we will check the VDRL titers, is it 6 months or 3 months?
Yes, sir. One of the panelists, can you take up? Sunil Sethi sir.
Say again, sir. Say again, please. Sorry.
The question is,
patient is actively treated with penicillin. Then when we have to do follow-up?
Serological follow-up.
VDRL. VDRL
normal
checkup.
patient, sir.
Patient is VDRL positive, treated with benzathine penicillin. Then when follow-up, after how many weeks or how many months the patient should be called?
Actually, normally the antibodies will come down within 6 months. So it has to be, the follow-up has to be actually 3 months and the 6 months, sir.
Yes, sir.
Okay. Another question from Dr.
No,
Nishant Gupta.
WHO and CDC recommendations are 1 month, 3 months, and 1 year.
Another question from Dr. Nishant Gupta. So how can we ensure he did not have any new unprotected the intercourse for 1 month after treatment?
Yes, sir. Datta sir. Rashmikant Shah.
Sir, I am not able to hear you again. Can you tell me again?
Yes, see the Venkataman sir, in the chat box it is there. How can we ensure he did not have any new unprotected intercourse for 1 month after treatment?
I could not listen to you because there is some other point going on.
Okay.
I'll just check it why it is so.
He asked the BN Reddy, traumatic ulcers are common on forchite following sex for the first time. Okay, thank you, sir. Again, biological false positiveness of pregnancy. Okay, that's okay. This all are covered. Yeah, we have covered everything, sir.
Right, sir.
One more thing, Mahesh, that is, she is asking about how we will assess the fresh exposure will be the, we have to advise the patient not to have the exposure, 1 month till 1 month after the treatment. That's very important. And we cannot assess, we have to ask the patient. That's only.
And practically not 1 month till
yes, 2 years, 2 years. 2 years.
Quizmaster.
Yes, correct, that's correct. As per book, 2 years.
Yeah. Right. Now we'll
but whether it is implemented per 2 years is possible, sir?
No. It's not possible. Right. Now we'll
Chairperson, sir, invite the quizmaster. So she will start the quiz. Datta, sir. Actually, it is Datta, sir. Sir, unmute.
Thank you, panelists. It was a very interactive session and very lively session where everybody took part. Fantastic. Now I request Dr. S.V. Kavita to conduct the quiz because we have only half an hour, I think, to 10. So, Dr. Kavita?
Yes, sir.
The stage is yours.
Instructions, Srinivas.
A very good evening to you all, sirs, my respected teachers, and my dear colleagues here. It's really I'm very happy to share this platform today. It is very lovely session, sir, and a very excellent panel discussion, and the speakers were also excellent. I now invite all our postgraduates for the quiz. So the instructions for the quiz are, there will be 20 MCQ questions and you should answer all. And mark 1 correct answer, and the duration of time is only just 10 minutes. And the first 2 toppers will be selected from this, from PGs as well as senior residency people also. And always the quiz master decision is final. So shall we start the quiz?
Yeah.
Yes.
Srinivas, have we released the quiz? Released, no?
Yes, sir.
Yeah. Now, so meanwhile, what we will do, it's a time to invite the Astinar stars to sensitize the genital health awareness. The display the Astinar stars TV. Yeah, so this the Astinar-1 Astinar stars are our former presidents, Dr. Bhushan Kumar sir, Dr. A.K. Jaiswal sir, and Dr. Loganathan sir. So now I invite Dr. Bhushan Kumar sir to create awareness on the genital health. Over to Dr. Bhushan Kumar sir. Srinivas, the PPT of Dr. Bhushan Kumar sir.
Thank you. Thank you very much. Umesh, you are a very dynamic person. Thank you for organizing all this. Now, this issue of genital health is very wide because these are the most important parts of our body for men and women. And now, as the Google and more information is available on the internet, and there are views and there is a pressure of selling something and trying to make the sex more attractive. So this is one issue which has drawn attention of most of the people. I have gone through some recommendations from the NHS, some OB-GYN Association of USA, and some other related agencies, which are considered to be more scientific, to provide this information. This is just I got in brief, which the slide shows. Of course, the first thing is that healthy body and healthy mind, they go together. So you have to be doing some kind of an exercise, doing good, having good food, and trying to behave responsibly in sexual and other issues related to that. Okay, what I have done, sorry. Yes. So now what is for the men and women, the things are little different, not much difference. For men, the penile health, this also includes the testes, no apparent pathology, no can urinate comfortably, no sexual dysfunction, no dysmorphophobia. Because when we are talking about genital health, this dysmorphophobia is the biggest problem. The penis is small, the penis is tilted, the penis is angulated, the penis has some red dots or white dots or something. So that is one thing. So if there is a dysmorphophobia, we will not consider it as a routine. So you have to deal with it by giving some useful information, trying to make the person aware about the physiology of that part, anatomy of that part, and also try to counsel the patient so that you bring in more confidence in that person. So dysmorphophobia is an issue in itself. I'm not going into details of this. Then in the men, there are two types of situations. One is circumcised and one is uncircumcised. Before I go to this, I just wish to add one word about circumcision, because Yogesh mentioned that circumcision is preventive. Initially, in the whole world, more so in the USA, there was a very strong kind of recommendation that all children should go through circumcision, which now has been withdrawn. And it is up to the parents that they want to go for this or not, because chances of suffering or having serious outcomes of the circumcision are more as compared to what they would be in a sexually transmitted infection. Okay, so now the circumcised person, the pubic area and the penis and the genital area has to be just, while bathing, cleaned with soap and water. For the uncircumcised, please pull back the prepuce and gently clean it soap and water. Too much of soap, too much of rubbing or harsh treatment or trying to clean it even with a rough towel is not recommended. And when the person has gone far or is good enough to have sex, condom uses is recommended, not only for the safety of the person, but if you are carrying some infection, for the safety of the partner. The other issue is about the hair removal. It's a personal choice. Some people would like to keep them because there are certain so-called these movies about sexual activities and sexual acts. Some show that the area is cleaned of the hair, and some try to retain the hair. They feel that it increases the pleasure. So that is a personal choice. The recommendation is that you can do either shaving or trimming, no depilatory, because that contains sulfides which can damage the skin. And of course, the nature has meant the genital area giving these different kind of scent in the men and women, but not supposed to smell like roses or smell like something else. So no strong perfumes to cover that area or to cover the problem of that area or infection of that area. Deodorants and strong perfumes are not recommended. Next, about the women. The information which I collected, they have classified the women into two groups. One is the young and the other is the menopausal. Again, the same like in men, no apparent pathology, no dysmorphophobia. The dysmorphophobia is not there in the menopausal segment because the woman has already gone through this phase. If it was there, either it still stays or she has taken care of it or she has been treated or counseled about that. So no apparent pathology, no dysmorphophobia. This dysmorphophobia is very selective and as bad in some women. I will bring in one word about the size of the nipple and so, but not bringing in the breast into this. But the dysmorphophobia can be of various nature. The size of the clitoris, the shape of the labia majora, the shape of the labia minora. Sometimes labia minora are larger than the labia majora. They may be protruding, and some feel that they are colored or discolored. The woman is fair and they are slightly darker, and some kind of a peculiar smell and some kind of a discharge. These are all the things which, or many more, which women complain about. And how do they feel about after sexual arousal? These can be only imagined, and these can only be sorted out once you see something or once the person talks to you. Now, in the menopausal woman, the question is of the genital discomfort. Genital discomfort could be because of a disease going on inside, some pre-malignant condition, or the discomfort could be related to simple vaginal dryness, and the discomfort could be all the time, and the discomfort could be only related to the sexual activity. So these are to be sorted out by history taking and examination. Sexual protection for both menopausal and younger women. Either you can use a male condom or a female condom, whatever is more convenient to you, but protection is a must. Maintaining of general health and hygiene. Now, again, the word is hygiene. Please see that excessive hygiene or over hygiene is not recommended, and it is harmful for the so-called genital area, which is considered as tender, more sensitive, and delicate. Clean with simple soap and water during bathing. Externally, please advise the woman not to insert the finger into the vagina or push the soap into the vagina or the whatever to clean, because the vagina is self-cleaning. You don't have to, you have to only clean the external area. So if there is some sweating, the sweat there, or if there is something else which you think is sticking, you can do that. Cotton panties not to be worn out strictly at night time. Clean the area front to back after sex or urination. This kind of a conception or the impression which most of the people, even men, have is that after sex, urination is a must. Urination may be helpful because the infection which can go to the urinary tract can be washed out before it settles there, but it is not a must that you have to do. You have to insist on cleaning or going for urination. Simple cleaning with a soft towel means we are talking about the semen and the other sexual secretions is good enough. Hair removal, like in men, personal choice, no depilatory. And the don'ts are very clear. No perfumes, no bubble bath, no deodorants, no douches. Again, the effort is to make the area more attractive from the smell point of view, that it should smell good. The V-wash, I had to put a query on this because this is a lactic acid preparation. I talked to the people concerned that what they recommend is that even the use of this area will make the area, what do they say, whiter. I can't say whiter, fairer. So now you can see that how to what extent the pharmaceutical people can go. It is not only to treat the infections, whatever infections you presume, also to make the area look fairer. So V-wash is a lactic acid preparation. If you are using it outside, your choice. If you can afford it and wish to use it, use it. But otherwise, if you think there are any extra advantages over simple lukewarm water cleaning or soap and water cleaning, there are hardly any. But I know of some gynecologists who are quite fond of using this V-wash in women who complain of vaginal discharge more frequently, are obese, or some have some features which could lead on to or a systemic disease, but they are quite fond of it. If you wish to use it, please use it. It is at least safe, but does not give you anything extra. You are using it, lactic acid is safe, 1.5%. You are using it on the outside, but please make sure that the person does not push this solution into the vagina. So this was the only introduction which I wanted to give about this important issue. And thank you once again for giving me this opportunity to talk to you all. Thank you very much. If there are any queries, I would be very happy to answer.
Yeah, thank you very much, Bhushan Kumar sir, for excellent initiation of awareness on genital health. Now the second Astinar star is Dr. A.K. Jaiswal sir. Over to Dr. A.K. Jaiswal. Yeah, you are muted, sir. Unmute.
Well, friends, at the very outset, good evening, and nice seeing all my beloved delegates and the faculty members of IASSTD after a very, very long time. Now, as far as the genital hygiene is concerned, well, Dr. Bhushan Kumar has not only given an introduction, I think he's given a complete detailed description and information about the maintenance of the genital hygiene. Yes, it is very important to have a good genital hygiene because it's an essential part of the personal hygiene and well-being. There's no doubt. And it is not from now, it is since ancient times, the importance of cleaning the private part, both from the urine and feces by using the stones is well documented. The hygiene intervention to reduce STI, this among men was an integral part of the programs for army men during the First and Second World Wars. As far the circumcision is concerned, well, as Dr. Bhushan Kumar has said, it is controversial whether it plays an important part in the prevention of STIs. Well, I think it has a positive impact on the maintenance of genital hygiene. To tell you frankly, in March 2007, if you remember, WHO recommended that male circumcision should be considered as a part of comprehensive HIV prevention package. Now, other part as far as how to clean post-coital and what all to be used, I think Dr. Bhushan Kumar has elaborated in quite details. And well, as far as the national level is concerned, I think in order to obtain and maintain good health, we need to take active steps at the national level also, both on the personal and on community levels. India has already taken a leap in the direction of launching national campaigns such as Sulabh Shauchalaya and Swachh Bharat Abhiyan. Now, these campaigns may go a long way in bringing behavioral changes, good education to the public regarding maintaining the genital hygiene. I think that's what I can add.
Thank you, Dr. Jaiswal sir, for creating awareness. Now the third Astinar sir is Dr. Loganathan sir. Sir is there. So if I don't think he is not visible. So the excellent way of creating awareness by the Astinar stars, the former presidents, we are honoring in this way Astinar sir. Not only that, all the faculties, now you are the Astinar stars. We request all the faculty and Astinar star, please create this awareness. And we will share your slide, Astinar star. Please share in your group, CVs, or any DP. So to create awareness on that. Because the people can tolerate the tragedy of earthquakes, calamities, but no one can tolerate the tragedy of bedroom. So it is our responsibility to keep that sparkle alive by creating awareness on genital health. So thank you very much. Now over to Quizmaster. Dr.
Here I would like to mention, Bhumesh, that Bhumesh, here I would like to mention that there is a society, Community Dermatological Society, which was formulated by first founder member was Dr. Sachidanand, and now the president is Dr. Ninima. Now they are coming with a book on skin and genital hygiene, and I happen to contribute a chapter on the genital hygiene and the male genitalia. I think that book will soon be out, and it will be of benefit to the primary school level as well as primary health centers level.
Thank you. Thank you, sir. So thank you for the information.
Thank you, General sir. Thank you for the information. Nice seeing you.
Please don't go away, sir. We'll take a group photo.
No, we are there, sir. We are there.
We will take group photo at the end. So over to Srinivas. Please release the answer key, and the quizmaster will read the questions. Then the results will be declared.
Yeah, the answers for the questionnaire is syphilis, also known as, answer is great pox. Syphilis is caused by bacterium. Treponema pallidum is grown in rabbit. Clutton joints are seen in congenital syphilis. Adult secondary syphilitic skin rash, mostly it is maculopapular. Minimum number of organisms of Treponema pallidum required for successful infection is minimum of 67 organisms. A hard chancre on the inner surface of prepuce may result in a snapping back of a retracted prepuce, which is called as dory flap sign. It is due to indurated base. Chancre redux is relapse of chancre due to insufficient treatment. Syphilis de-emboli means primary stage is absent. Condylomata is secondary syphilis. Dark ground examination for diagnosis of syphilis has sensitivity of around 40 to 50%. Reverse algorithm, that is treponemal test followed by non-treponemal test, it has got the following advantages. It can detect more cases of early as well as latent syphilis. After how much time VDR antibodies come to baseline when treatment is given in primary syphilis? It is around 6 months. The definitive diagnosis of neurosyphilis is by which of the following tests? Reactive serum as well as CSF VDRL. Congenital syphilis can be diagnosed by the following test. It is mostly infant IgM ELISA. Drug of choice for antimicrobial resistant gonococcal infection is ceftriaxone. Male condom is highly protective against all except HPV, human papillomavirus infection. Infection with which of the following virus may result in fetal malformation? It is Zika virus. Diagnostic accuracy of syndromic approach is poor in vaginal discharge due to cervical infection. The last one, adult between 16 to 49 years, prevalence in India. Adult prevalence in India is around 0.22% is the correct answer. So may I know the results? So the winners of this Astinar-1 they are winners from the senior residence. She is Dr. Juhi Fatima Sultana from Deccan Medical College and Dr. Divya Bhatia from PGIMO. And among the postgraduates, Dr. Prashanti from Government Medical College and Dr. Ketan from JIPMA. So we hearty congratulations for all the best performance and all the HODs of the respective institutes. A very hearty congratulations. And I congratulate even all the participants who have really participated in this seminar. It's an excellent CME, which every postgraduate should utilize this for their best performance in STDs. Thank you very much for the organizing team for giving me this opportunity. Thank you all.
Can I add a word?
Please. Bhushan.
About two questions. One is the condylomata lata should be the word clearly, not only condylomata. The second was about the minimum number of organisms which can produce infection in a human being is 67, but experimentally one treponeme injected into the testes of the rabbit is good enough to produce an infection.
Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you, Kavita. Yeah, thank you. It's a time to the vote of thanks. Dr. Mohan Kumar.
Yes, sir. On behalf of our IAS study aides, I am honored and my sincere thanks to Team Hyderabad for making this academic event in the reality. So we started the academic event by our senior persons, Professor Arun Ladda sir and Dinesh Goyal sir started these sessions under the aegis of our Professor Umesh sir. So the academic sessions, the overview from our editors are in the clinical diagnosis and syphilis differential diagnosis by Professor Hanumandiya sir from Kolar, and assisted by the laboratory diagnosis from Chandigarh PGI, Professor Sunil sir. So the next panel discussions regarding the clinical changes, managements, issues in detail by our moderator, Professor Venkatamana sir, with assisted with our Professor V.K. Sarma sir, Rajiv sir, and Asmikant sir. So the extended PG quiz moderated by our Kavita madam. So by the meanwhile, our Astinar sirs, our Professor Bhushan sir, once again enlightened regarding the healthy genitalia, healthy skin, mind, and healthy nation, sir. Also, the inputs from A.K. Jaiswal sir regarding the community health. So my sincere thanks once again to the team Hyderabad, led by Professor Netha sir, with the assistance of Bhumesh sir and Rajiv sir, and the knowledge partners, Hetero Healthcare team for the technical assistance academic grant. Once again, I am thanks to all the participants making with us. Once again, a good beginning. Thank you, Hyderabad teams, for making this academic event wonderful.
Thank you very much.
Yeah, few points. Dr. Chandrasekhar Rao, sir. Chandrasekhar sir, are you there? Yeah. Chandrasekhar sir. So, if sir is not responding, so thank you very much. So finally the special thanks to all the delegates. So those who have participated, more than 256 they have participated. We thought the first Astinar would be 50. We thought of it, will it cross more than 50 or not? So now it has crossed 256. So really it's a good start. We request all the faculty members, please spread this message for the PGs and the SRs and your faculty. So with this, thank you very much, one and all. And we'll conclude this Astinar-1. So we'll see in the Astinar-2 in the third Sunday of the next month. So before that, we'll have one group photo, please.
Thank you, Bhumesh, for everything. You are the real hero.
Yeah, Umesh, you are really fantastic.
Yes.
And organized in such a way that you really...
I totally agree with Bhushan Kumar sir and Aran. I totally agree. I think he is really one of the dynamic person as far as the ISS study is concerned.
Absolutely.
2 minutes before we close. We finish 2 minutes before. Thank you. Thank you very much.
Thank you. Thank you.
Thank you, Dr. Narasimha Rao sir. And thank you, Umesh, but to bring the
thank you,
to the next level. To the next level.
Thank you. Thank you, the president.
We have lunch.
Yeah, Dr. Murugan.
And Govil sir, Janal sir.
Thank you. Thank you, sir.
Thank you, Murugan.
Thank you, sir. Thank you.
Govil sir, co-chairman sir.
Kavita ji, thank you.
It was good.
Kavita ji, you are really good.
Thank you all for sharing.
Really, we are having a nice feast, nice clinical feast and informative.
Really,
it was a very nice section. Very
Thank
interactive.
you once again to everybody. It was a pleasure. It was a pleasure.
Thank you, one and all. Thank you very much.
Good night.
Good night, sir.